the illustrations, that the idea that one person can make a difference. How many people believe one person can make a difference, right? That they provide hope and they provide real help. And when I look
Hello everyone, this is Farah Batul and I welcome you all on day 4 IBRO APRC Associates Brains from Neurobiology to Psychopathology. We have our first speaker, Dr. Jerry DeVore. Hello sir, how are you?
Oh, can you hear me?
Yes, we can.
Okay, well, it's a pleasure and an honor to be part of this presentation.
Same here, sir. Same here. Sir, actually, I need your permission would you like us to play your video or would you want to go live?
Yeah, why don't you do the video since I've already recorded it for you, and we did that
Okay.
so that. But I will stay online so that after the recording's over, if there's a few minutes, I could address any questions that might occur.
Thank you so much, sir. Your presence means a lot. Thank you. For all the participants, I request that you should off your cameras and mute your mics to avoid any disturbance. Dr. Jerry DeVore is a clinical psychologist licensed in the state of Washington. He completed his PhD in psychology at St. Louis University. Dr. DeVore has had a career including 20 years of federal service with 11 years active duty. He has been a faculty member of an APA-approved internship program while on active duty. As a civilian, he was the director of rehabilitation psychology in Physical Medicine and Rehabilitation Center, Good Samaritan Hospital, where he worked for 18 years. Dr. DeVore recently retired from 20 years of federal service and now has a private practice in an integrative healthcare center focusing on treatment with biofeedback, neurofeedback, hypnosis, and EMDR. Dr. DeVore is a diplomat of the American Board of Professional Psychology in Clinical Psychology. He is also a BCIA certified in general biofeedback and neurofeedback. He is an approved consultant in the American Society of Clinical Hypnosis. He is level 2 trained in EMDR. Clinically, Dr. DeVore is fascinated with the ways in which biofeedback, neurofeedback, and hypnosis can foster health recovery and health resilience. He is also fascinated with such as hypnosis, and he regularly presents in the area of experiential spirituality. Thank you so much, Dr. Jerry DeVore. We're glad that you're here with us.
Thank you. I'm a clinical psychologist, and I'm honored to be invited to present at the International Brain Research Association meeting. And today I would like to talk with you about a theme that we'll get up with my PowerPoint in just a moment. And that theme is assessing neurocognitive disorders in gerontology. And my background for talking about this area is that I'm a clinical psychologist with intensive training in psychophysiology and physical medicine and rehabilitation. In fact, I'm the former director of a rehabilitation psychology department in a physical medicine and rehabilitation hospital with an inpatient and outpatient service. So some of you may not be aware of what physical medicine and rehabilitation is. It has a functional orientation, or an orientation that doesn't necessarily aim to cure people of a disease, but to help them function better. And the kind of disorders that we treat in a physical medicine and rehabilitation facility are disorders that go along with traumatic brain injury, strokes, dementias, not so much delirium, because delirium tends to be a fairly temporary condition and is typically treated in medical wards. I also treated people with spinal cord injuries and people with industrial injuries, strained muscles that create chronic pain and reduce mobility. Sometimes recreational injuries will also produce those kinds of debilitating conditions. And so I got to see quite a variety of folks, from people with chronic pain to traumatic brain injury to lesions in their spinal cord, to people who had progressive dementing conditions and how that affected them, and how that contrasts to people who had a brain disorder due to a stroke that, depending on where that stroke occurred in the brain, created different kinds of behavioral problems for the patient and for people who are in the patient's community. In addition to being a former director of rehabilitation psychology, I'm currently a adjunct faculty member at Saybrook University, and there I teach anatomy and physiology for applied psychophysiology. I teach neurostimulation technology, and I have taught fundamentals of psychophysiology, in addition to which I've had many years of clinical practice. So now I'd like to having sort of established that I have some background and credentials to talk with you, I'd like to get on to the main topic of, well, how do we parse out and begin to understand neurocognitive disorders in gerontology? And often there's a nice twofold distinction between dementias and delirium. In fact, I got ahead of myself. So with delirium, the hallmarks is that it's an acute fluctuation in cognition. It can be quite severe. People can be out of touch with who they are, where they are, why they're there. They can be out of touch with time, and that can clear up fairly rapidly depending on the physical cause. And that brings us to the second element of a delirium, that there must be a related physiological precipitant of this condition. You can't really make the diagnosis of delirium without identifying what has physically caused it. And that's actually crucial. If the delirium is due to with alcohol withdrawal in a person who's a chronic high using alcohol abuser, that delirium needs to have a significantly different kind of management than, say, a person who started using chemicals like LSD or mescaline or psilocybin and had similar kind of symptoms. The treatment pattern is entirely different. And that's also entirely different than people who have had toxic exposures to various products or sometimes fever-induced delirium, various kinds of encephalitises. All of those things are part of the neurology and the medical disorders that medically trained personnel, physicians, that's their realm. I'm a psychologist, and I can talk about fluctuations in consciousness, adaptive behavior, and those sorts of things. But in terms of tracking down the causes of delirium, that's mostly a job for physicians. And as I've been alluding to, careful assessment of the condition leads to much better treatment outcomes. Now let's go to the slide on dementias and other chronic conditions. So where delirium was acute, dementias tends to be chronic. And actually a lot of chronic degenerative disorders were lumped together as dementia. And the term dementia came to have sort of a pejorative or insulting kind of connotation. These days, the term dementia may be used for people who have progressive cognitive degeneration, especially if they're older, such as Alzheimer's disease. But there are some other brain diseases that are different than Alzheimer's, but involve progressive loss of psychological functioning. There are other kinds of folks who rapidly, dramatically, acutely lose functioning, and that would be people who might have had a traumatic brain injury or who have had a sudden insult to the brain, such as a stroke. Or sometimes medication or procedure reactions. The importance of making these distinctions is because the different conditions involve a different neuroanatomy and a different neurophysiology, and hence a different neuropsychology as well. And just like with delirium, careful assessment leads to improved treatment outcomes. Well, how do we make that careful assessment? Well, one of the ways is to track the neuroanatomy and neurophysiology of the patient. That's certainly how we started learning about these conditions in general and in doing medical research. And to help us with that tracking, there is structural imaging that uses X-rays, CT or computed tomography, and MRI, which stands for magnetic resonance imaging. So structural imaging tells us about anatomy, but we're more interested in how things function. And so it turns out that there's some functional imaging that has already told us a great deal about how the brain and related structures function. One of the methods of functional imaging is positron emission tomography, PET. And then I think there's also SPECT, which is, I think, a single photon emission computed tomography. These both they require radioisotopes that have a very, very short half-life, but they're injected, and typically they involve something like sugar or oxygen that are consumed in the areas of the brain that are most active. And you have a person engage in an activity, inject them with this isotope, and then take a map of the radioactive locations where it's most concentrated. And so you can get some quite remarkable images of what areas of the brain are activated when we engage in different kinds of activities. Well, it turns out that the functional magnetic resonance imaging also tells us about the brain when it's doing things. And that's because it uses a signal derived from blood oxygen. And it turns out that oxygenated blood flows to areas of the brain that need it because those areas are working hard. And the fMRI can detect those changes in blood flow and give us a very detailed, down to about 3 millimeters, a detailed picture of what's going on in the cranium and in response to some task that the individual is doing. Finally, on the list that you won't find on many lists, I'm kind of surprised that there's an EEG technique that actually quantifies the EEG signal. And the LORETA stands for low resolution electrical tomography. So this is another tomography approach, but it's a way of mathematically analyzing 19 or more channels of EEG signals to backtrack to where those signals are likely to show up in patches of brain. So I'm now going to give you some illustrations about these ways of tracking neuroanatomy and neurophysiology. So here we have structural brain imaging. And on the far left, there's axial magnetic resonance imaging. In this case, you can see that white space reflecting grossly enlarged ventricles that occur in normal pressure hydrocephalus. In the middle, there's axial computed tomography showing a left subdural hemorrhage. Now, when you look at this image, the axial CT, you'll actually see that the squeezed ventricle caused by the hemorrhage appears to be on the right side, but for some reason the convention is in CT and often even in fMRI that the right side of the image is the left side of the brain. In fact, you can actually see that at the far right, the axial MRI that shows the large left frontal temporal meningioma. And if you look, it's pretty easy to see at the top, which is the front of the brain. There's a big area that's really quite different than the rest of the brain. And it appears to be on the right side of the image, but that image is actually reflecting the left side of the brain. So that's structural brain imaging. Looking at the anatomy, it doesn't tell us how those areas are functioning. Now we have functional imagery. So that these images are done with PET scanning. And on the far left, there's the normal brain. You can see that, well, those areas that are dark, those are the areas, the darkest areas are the ventricles. So they aren't making use of that radioactive substance. They're not metabolizing anything because they're holes filled with cerebral spinal fluid. But around the rest of the brain, you can see a great deal of activity. Red means more activity. So there's a lot of activity down the midline of the brain and around the rest of the brain. When a person has a mild cognitive impairment. So mild could be still able to do normal activities of daily living. But as you can see, the brain is compromised even in a mild condition. Now, there's as people who track cognitive impairments, when they tend to be in a mild level, we expect a good deal of improvement over the course of 6 months to 12 months. And when things are acute, however, the brain looks or can look something like this. You see the left and right, there's these patches of green, kind of in the lower left and lower right, and they should be patches of red. And so those are areas of the lower parietal areas, and maybe even branching into the temporal areas. And you see at the front of the brain, there's a red area down the middle that is present in the normal brain but absent in the mild cognitive impairment brain. Well, that's the anterior cingulate cortex. And then if you look to either side, the areas of red are much smaller compared to the normal brain. Well, that's called the dorsolateral prefrontal cortex. And the dorsolateral prefrontal cortex is absolutely crucial for being able to conduct executive functions. Making decisions, planning, making sure that you're carrying out your plans. So even with mild cognitive impairment, there's a lot of areas of functioning that could be compromised. And then we look over to the far right, and we see that with Alzheimer's disease, the brain looks a lot more compromised than with mild cognitive impairment. There's just a lot more real estate that's offline. Those areas around the ventricles, some of those areas have become dark because cortical matter just isn't functioning and taking energy the way it should be. So that's functional imagery can tell us quite a bit, though usually functional imagery is used for research purposes rather than regular, hospital-based diagnostic imaging, because the imaging procedures is very expensive, and many hospitals commit their resources to other kinds of procedures. And then there's an area that I mentioned that uses EEG, at least 19 channels. The system I have is a 19-channel system, and it measures The 19 channels come from sensors that are on a specifically charted map of the head, and so they're located in what's called the 1020 EEG site locations. And then if you take the information that the sensors get from each of those 19 channels, you can mathematically transform them to project what would be happening in various areas of the brain to produce that pattern. And that's where, and that turns out to become the low resolution electrical tomography. And here you have an image that shows a person that was hit on the right side of the head. You can see in the lower right box, there's that big area in the back of the head. He was hit there with a baseball bat. Unintentionally, but nevertheless, you look at where that big red area is the surface potential that's measured at the scalp. And then the other three images are projections onto a general MRI map of the brain, but they're the Loretta projections of showing the areas of compromised functioning. So we can actually see that that being hit by the baseball bat has compromised quite a bit of the cortical real estate, and that's important for a variety of purposes. One, you can track progress. We don't expect TBI or traumatic brain injuries to progress, but we do hope that if we do good treatment over a period of time, that they might get better as the brain vasculature sprouts new connections, and as the neurons, the intact neurons, find new pathways to connect. In any case, those are a kind of quick introduction to the imaging technology that's available to modern science, and many of the imaging techniques have some translation into to modern medical practice as well. But besides the imaging, there are other elements to assessing neurocognitive disorders. There are labs that, urine analysis, blood analyses, quite a variety of ways of taking samples of tissues and fluids to help clarify the diagnostic picture. There's always the physical examination and getting a good history, not only from the patient, but also from family members or people who know the patient well. Then there's the mental status exam, and a particular standardized sets of mental status exam. One's called the mini mental status exam, that's often used to assess people for dementia. There's also, and that's the mini mental status exam is MMSE. And then there's the Montreal Cognitive Assessment, called MoCA for short. And it's useful to have sensitive measures that can still be measured briefly. And what I mean by brief is some of my psychology colleagues are neuropsychologists, and their notion of examining a person's neuropsychological functioning typically involves an 8-hour assessment process. So the MMSE or the MoCA, may take 30 minutes at the most. So it gives you a brief, potentially rough and ready assessment, but it certainly doesn't give you a detailed assessment the way that an 8-hour rigorous evaluation would. And then it's important to consider the team who's part of doing the assessment. An office clinician, for instance, may order neuroimaging, but doesn't perform the procedure. So radiologists often are performing some of the procedures, and they're very crucial to the healthcare team in assessing for anatomic irregularities. And some hospitals, particularly ones that are likely to see people with traumatic brain injury or strokes, neuropsychologists are often part of the team because they can assess and clarify functional, cognitive, and emotional components. And basically, my practical philosophy is that healthcare is a team player activity. No single clinician, no matter how bright they are and how rigorously they were trained, no single clinician can have access to all the resources that might be needed to understand the features that are dysregulating a patient's functioning. Additionally, treatments are best conceived of as plans that involve multiple providers exercising important skills to manage and treat the disorders and diseases in an optimal way. The patient may not need the team all the time, but a wise clinician has developed a network of consultants and colleagues who can be assembled as a team if needed. And we also need to think about the purposes of assessment, because diagnosis is not the only purpose. So when we're disease focused, we want to do a good differential diagnosis because we've already seen that knowing the difference between delirium and dementia and what's causing the delirium, what's the nature of dementia, and are we sure that it's dementia? Because depression sometimes looks like dementia, but depression is not a progressive disorder. And with the right kind of treatment, people with depression recover in a way that people with progressive degeneration of brain cells, it's very, very much more challenging to recover. And you also need to be able to distinguish between dementia and cerebral vascular accidents or multiple sclerosis. And additionally, when we're looking at a disease and we've done the differential diagnosis, often for conditions there are staging. So for dementia, people may start to go into dementia, but only be mildly affected. Other people are moderately affected, might need to be supervised around the house and perhaps discouraged from using knives and other kinds of implements that could be used in a harmful way. And then there's severe dementia that may leave the person incapable of doing much of anything, so that they really need care providers to address basic biological and psychological functioning. Well, there's a different kind of focus for assessment, and that would be a functional focus. So in a functional focus, you're looking for resources that the individual might have, preserved habits, abilities, capabilities, what those resources that might help adaptive functioning. You're also looking at family members, economic resources, social resources, all the kind of things that potentially could be mobilized to help the person have a high quality life. You also want to look at the rate of decline in function or the rate of improvement in functioning. As I mentioned earlier, with people with mild cognitive impairment, particularly if that impairment was produced by a concussion, you would expect those people to improve in their functioning over the course of 6 months to a year. Sometimes you have to look at competence for decision making. Is this person who used to drive now competent to drive? Is this person who used to be able to sign legal documents and represent themselves, can they still competently do that? And then there's the issue of ADL stands for activities in daily living. What can the person safely do on their own? Sometimes conditions result in significantly compromised motor control, so the person can't walk on their own. They may need to be in a wheelchair, and they may need assistance in moving that wheelchair around. And then we have the issue of functional independence, or what can the person do on their own, and how much help do they need? Because sometimes people are not independent, but they don't need a whole lot of help. And then finally, there's a purpose of assessment that involves planning treatment and managing both, or including the disease, functions, and the environment. So all of those things need to be assessed so that a really good treatment plan can be worked out for the patient. So in the assessment process, there's the initial evaluation that typically involves background records reviews, current history of health and psychological functioning, physical examination and labs, family and caretaker and other environmental aspects, the neurologically oriented mental status exam, sometimes neurocognitive screening, and perhaps a neuropsychological evaluation, including quantitative EEG and event-related potentials. And now we're going to talk about some screening instruments, the mini mental status exam and the Montreal cognitive assessment. Screening instruments are aids to diagnosis, but how well they work as an aid depends on their reliability, their validity, their sensitivity and specificity, and other psychometric properties. So reliability is if you take a reading now and you take a reading tomorrow, are the readings going to be the same or a lot different? So if they're a lot different, if a reading today shows a real low level of functioning and the reading tomorrow shows a real high level of functioning, that would be inconsistent with a diagnosis of a dementia, because generally dementias are a downhill course and they don't really have a whole lot of improvements, but sometimes you see brief improvements because they had a fever or were not getting a good night's sleep, and when you first tested them, and they now get a much better night's sleep, and so they have some improved functioning. But reliability is whether the score, whatever it is the same over the next period of time that you sample, which might be later in the evening or the next day or the next week. Things that are very unreliable are also undependable. Validity, on the other hand, really asks, is these test challenges, is the questions or the tasks, do they really assess what I'm trying to assess? If I'm trying to assess language functioning, are the questions that I'm asking give me a good assessment of that functioning? So that's what validity is about. And the sensitivity and specificity is, sensitivity is to note whether things are about normal or are they significantly different than normal. Specificity really identifies if they're different, are they also different from other things that are abnormal? Or is this just more of a general indication of something that's not normal? Progress monitoring is another thing you want to do with screening instruments, but to monitor progress, you have to be able to detect small changes, and specific abilities such as reaction time might be more useful than general screening kind of tasks. So the mini-mental status exam is the most widely used cognitive screening instrument. It provides a cognitive or quantitative cognitive mental status exam, whereas some of them focus more on whether a person is psychotic or focuses on emotional activation. This addresses cognitive aspects, including orientation, attention, calculation, recall, language, and motor skills. You get 30 points at the max, and scores below 20 points are said to discriminate cognitive impairment compared to no impairment. Some research suggests that the scores between below 27 or 28 give you the best sensitivity to specificity. But that also means if 30 points is the max, there's only a 3-point difference between being normal and having some cognitive impairment. So that doesn't give you much room to detect improvements. So that's a problem with the mini-mental status exam. Let's take a look at what that exam involves. So yeah, so here's a form that I copied off of the internet, in which you have these orientation questions. Then you have the object recognition registration questions, where you basically they give the name of 3 objects, a spoon, a cup, a car. And then as soon as you said that, you ask the patient to repeat that back. And usually people can repeat them all back, but if they don't, you give them 3 tries. And give 1 point for each correct answer. So you can see ultimately how many trials it takes to get all 3 correct. And then there's an attention and calculation. Serial sevens is you take a number like 500. I want you to count backwards by 7, starting at 500. So 500 would be 500 minus 7 would be 493. Minus 7 would be, and you keep on going. You give 1 point for each correct answer. You stop after 5 answers. The alternative to that is, and this is where, obviously this test is giving instructions in English, but there are many translations of the mini mental status evaluation. So you certainly want to use a version that's appropriate to the culture that you're working in. They can spell a word backwards. That would be an alternative to serial sevens. Recall is then asking for if people remember those 3 objects that you named. And then language assessment is you have them name a pencil and a watch, repeat a phrase, no ifs, ands, or buts. That again may be, culturally sensitive, and you'll have to see how well that translates in whatever culture that you might be working in. And likewise, there need to be the proper translation for following a 3-stage command, following an order like close your eyes, and having them be able to write a sentence. That's some areas where we assess people, people haven't learned to write. So that wouldn't mean that they're demented if they're not able to write a sentence. It may mean that they didn't have the cultural experience of learning to write. And then there's the copy of the design. So there are many people for whom this kind of examination is appropriate. There are a number of conditions where it's not appropriate. And that's where you need to be a discerning clinician. The Montreal Cognitive Assessment is said to be several steps above the mini mental status exam. It also is a structured, cognitively oriented mental status exam. It's got 30 items. It samples several domains of functioning, provides a quantitative score that allows you to track changes. It has established reliability. Testing at time 1 is correlated with testing 30 days later. The best sensitivity to specificity is with a cutoff at 24 to 25. So you get a little bit more leeway with the MOCA than with the MMSE. A person could be at 24 and still have room to improve. Of course, if they were much lower, they would have a lot more room to improve. It's a screening instrument that has some of the benefits, like using an EEG to diagnose seizure disorder, which would namely be detecting the presence of a low score indicates disrupted functioning, but normal range does not mean a normal brain. And for those of you who don't know EEG, when a person has a seizure, it's completely obvious on the EEG. It changes its character in an unmistakable way. So if you see a seizure disorder on an EEG, they have a seizure disorder. But if you don't see a seizure, it doesn't mean they don't have the disorder. It just means that you didn't see a seizure during the time that you were recording. When it comes to mild disorders, neither the MOCA or the mini mental status examination is very good. And so that could come up with a person who is starting to be demented, but they're still functioning fairly well, so it's hard to pick up. You have to look at subtle signs that perhaps the family describes that the person used to be able to do but can't do. You also have to learn how to administer it, and the people who control the instrument have procedures for signing up for the course of learning. So this is an example of what the test looks like. Those little dots above are a tracking task. You start off with you start off with 1, and then you have to go to the first letter of the alphabet, and then 2, and the next letter of the alphabet until you connect them all. That's called the trail making test. And that may have problems with different cultures that may represent letters of the alphabet in something different than what we use for the English language. Over on the right side, there's this strange looking cube. You ask the person to copy that. And then on the far right, you have a person draw a clock and indicate the time of 11 past 1. So all those tells you important information about areas of the brain. You have picture naming, a memory test, an attention test, a language test, abstraction, delayed recall, orientation. All of those are part of being able to assess crucial information processing related to brain functioning, and particularly areas that get compromised with Alzheimer's. Now, when it comes to, because part of why I'm going through this is because the questions we ask on those exams relate to functions in the brain. And many students learn about hemispheres and lobes of the brain, and they may even learn about specific areas like Broca's areas and Wernicke's areas that are very important to speech comprehension and speech production. They may even learn about the insula, because the insula is the area of the brain that's responsible for literally our gut feelings. The insula processes information about that come from our viscera, and they help us have that kind of intuitive feeling of something's not right or something's all right. It's actually part of the salience network that helps us identify what's important to pay attention to. Well, hemispheres and lobes are anatomical, but they don't reflect much functional organization. The Brodmann areas in the brain are the building blocks of cortical functioning, but even they, it's not like there are specific areas, there are networks of areas. So Brodmann areas are connected to other areas of the brain, and those connected areas accomplish a lot of the important work that we need to be able to do in order to use our brains to help us adapt. So some of those networks include the attention network, the executive function network, and the default mode network, the language network, and memory network. And the nice thing that what I have up here to remind me is that there's a program that I have called NeuroNavigator that I can do an EEG assessment of a person, and I can actually identify what's going on electrically in each of these networks. And so now we're going to see whether I can switch over. I'll stop sharing for a moment. And switch over to looking at the brain. So you're looking at a brain here. On the left, you're looking at what's called an axial view, as if you just sliced across the brain from the forehead to the back of the head and took slices up and down from that, that's what you'd be seeing. So in the middle are the ventricles, those dark spaces that we saw in the fMRI a few slides ago. And then around the middle, and I think these are also the fibers, and the fibers don't themselves generate electrical activity. So what we've got around that's colored is the cortex as it's generating electrical activity. And down here we've got some charts to tell us for the overall colors, it's telling us how intense a particular frequency is. So right now I've got this mapping the intensity of theta waves throughout the entire brain. So when things are more red, they're more intense. When they're green, they're kind of average, and when they're blue, they're less intense. You can also see that there's some lines below the brain, and so that's a way to see those lines. So these are each of these points where you see lines coming off. Those are Brodmann area nodes, and those nodes in the networks, they're connected to other nodes. And what this scale at the lower left is telling us is that things that are red have a high level of connectivity. Things that are blue have a very low level of connectivity. So in this map, you see there's some areas that have pretty high connectivity, but mostly there's not much connection. So with Loretta imaging, we can look at the activity of different patches of the brain. We can look at how they're connected with each other into different networks. So this was the default mode network. And just to quickly show you, so a different network is part of the executive function. And then there's even a different network for the salience circuit. I mentioned these three circuits because 80% of neurological conditions, including psychiatric conditions, result in dysregulation in one or more of these three networks, the salience, default mode network, and the executive function network. You can visualize that on functional magnetic imagery. That's very expensive, or you can image neural activity using Loretta in a way that's far less expensive. So you can also see that you can look at the overall cortical activity as well as the connections. We can change bands, so there's activity in the alpha band. And this is how we can detect information throughout the brain in the different circuits, so that we can identify the Broca's areas and Wernicke's areas and see how impaired they are. And all of this information helps us formulate treatment options that might help us modify the environment, modify the individual, or and those modifications should all be done in light of the treatment goals. One should consider safety, including activities of daily living, driving, weapons, and dangerous equipment. Is the person competent to engage in those activities? At the same time, we want to consider the least restrictive environment, because we all like to be as free as we can be. We need to consider the quality of life. Sometimes we can't cure a problem, but we can often do things that make the quality of life better, or keep it as good as it can be. And we need to consider the availability of resources. So with that, my wishful thinking is that there are EEG-based assessments that look at the brain when it's actively generating event-related potentials, and Loretta imaging. They may tell us a lot about what's going on with the cortex, and they may help us identify neurofeedback techniques as well as neurostimulation techniques that can help further slow the progressive rate of degeneration, or in some cases, we may even be able to reverse it. So I thank you for your attention, and I think we still have a few moments for questions.
Okay, sir, that was a great informative session. There is a question. A participant has asked that, can this technique be used for real-time imaging?
For what?
Real-time imaging?
Yes. That's one of the things that's really great about it. You can actually have a person, you can have them sitting in a resting state, and you can watch what happens with their brain as they're resting with their eyes open or eyes closed. You can even see how things change over the course of minutes. To usually people with an EEG cap, you can sort of tolerate wearing that cap for about an hour. So you can look what's happening with the brain. You can even look at when people are doing things like solving mathematical problems, or listening to speech, to see, if a person is listening to speech, does their auditory cortex light up the way we should expect it, or does it not? So those are that real time gives you some clues about what people are doing. It's also in terms of treatment, neurofeedback looks at the brain in real time, and we use various strategies to say, if we look at a dysregulated pattern and we identify what's moving in the direction of being more regulated, then we can give the person a reward, like a tone or a visual image, every time the brain moves in the direction of better regulation. So we can actually train the brain to function better.
Okay, sir. if anyone has more questions.
Hello, Dr. Jen.
Hi, Sadaf.
Thank you so much for just making this effort for all the students from Asia Pacific region.
Yes, well, it's a pleasure and an honor.
Thank you, sir. Sir, actually, there are some students who are actually here in the Zoom, and there are almost 200 students who are watching us live on the YouTube channel.
Wonderful.
Because we are live as well. And these are the students selected by IBRO who will be presenting their researches as well. Sir, we have another question for you. Farah, can you narrate, please?
Sir, Shuja Heather wants to ask that if dyslexic patients can be treated with this neurofeedback training or techniques.
Yes, quite a number of dyslexic patients. You can actually see in the brain what areas are not functioning the way they're supposed to. And then, as I mentioned with neurofeedback, it's usually a combination of neurofeedback while people are actually doing some reading tasks. So when a person's doing reading tasks, that's when the dyslexia is likely to be most noted in the brain functions. And then you arrange for the system to give you like a tone every time the brain moves into a more regulated status. And there's actually some decent research, suggesting that dyslexia can be both isolated and treated with neurofeedback. Yeah, and I think the question was saying, would that be true if it was just dyslexia, or if it were dyslexia as part of another condition? Well, if you're looking at the neurofeedback, there you've got the Wernicke's area, you've got Broca's areas, and then you've got other areas that those connect to that are responsible for language functioning. And typically with dyslexia, you'll find that some of those brain patches and networks aren't functioning the way they're supposed to, no matter what other condition might go on. And so you can actually have a fair chance of treating it.
Sir, we have another question. Can we use this imaging technique to detect the changes in brain that happens before epileptic seizure or onset?
Yeah, that's the if we it would certainly be nice if we could predict when a person might have a seizure before they have the seizure. And I'm not aware of anybody doing a really good job of that. But part of it is typically people who have a seizure disorder will show epileptiform signs in their brain waves well before they have a seizure. But you don't know that I'm not aware of any research that says, well, if you show these signs, it's likely in the next couple of weeks that you will have a seizure. So it doesn't have that kind of, you can look at an EEG, and even if a person doesn't have a seizure, you can say, brains that have this pattern are probably going to generate seizures, but you can't say when that seizure would occur. And then the problem comes in as, well, if you've got that, what do you do about it? Because neurologists are rightly reluctant to provide medications until a person actually has a seizure. And the reason for that is, well, seizure medications can be very effective. That's the good part of it. But seizures, because they stabilize the brain, they also make you drowsy. Because it reduces brain activity. And so the medications that can be very beneficial to control active seizures can also be harmful if you're not actually having a seizure. And this is where neurofeedback can really help neurology out, because again, you can look at those epileptiform discharges, and you can actually train the brain to really reduce how many discharges, and actually to reduce the number of seizures and how bad seizures are. There's a if people are interested in this, you should look up the research by Barry Sturman, because he's the person who actually documented that you can treat seizure disorders with neurofeedback quite successfully.
Thank you, sir.
Sir, I have a question. First, I would narrate the questions from Shuja Heather. Shuja is asking about that how delirium cause our genetic mutation. Delirium causes genetic mutation.
Well, it could if the genetic mutation leads you to periodically have toxic states in the brain. Then you could be prone to having deliriums, but or if it leads you to being sensitive to certain kinds of chemical substance like phenylketonurias. So you can have. So remember, delirium has to have a fairly immediate physical cause, but genetics can make you vulnerable to quite a variety of causes. So we'd say dementia or delirium is not a genetic disorder itself, but genetic disorders, if they make you prone to respond in a toxic way to certain kinds of conditions, then genetics can make delirium more likely.
Thank you, sir. Sir, I have one general question about these importance of these techniques, mainly the neuroimaging techniques as a biomarker for the neurodegenerative diseases. That I have found certain guidelines that there are some MRI and there are some other PET scan changes that can be included as in the diagnostic criteria. But what is exactly the importance of MRI and PET scan in diagnosing it at the earlier stage or something like that? Because there are so many factors that the normal physiological conditions lead us towards the degenerative disorders, mainly dementia or motor disorders, and then it develop into the later stages of Alzheimer's and Parkinson's. So how and where should it can be included as a biomarker?
Yeah, I think when usually it's family members more than individuals who begin to think that this person isn't just having a bad day, that they're not tracking information well. They're not doing things that they used to be able to do. And so often you'll see, signs that the person's just not behaving with as much intelligence as they used to. Given familiar things, they can do it, but unfamiliar challenges that they would usually be able to cope with become more of a problem. And so then you begin to think of, well, we need to understand what's going on here. And that's where you might talk with a physician. And typically they will do something like a mental status exam. They'll do a neurological exam, test your reflexes to look at whether there's an overall general neural degeneration or if it's limited to the brain or sometimes if you're lucky, you might have psychologists who are trained to do functional assessment. So psychological exams are a little bit more precise and more comprehensive than a screening evaluation. In fact, the more subtle or sort of the initial stages of a condition actually takes more work to assess, because you've got to look at, well, how do I know that this isn't just a bad day? Because most of us, we've had bad days. We're not functioning as well as we function when we're having a good day. But so with a psychologist, we pose tests, and we know how normal people should respond. Even normal geriatric patients should respond. So you can look to see, one, is there evidence that the person is not, is they're declining in their functioning? And then I alluded to one of the mistakes that a lot of people make is depression can show that same pattern. And geriatric patients, because sometimes their role in life sometimes is no longer as valuable as when they were workers and active family members. So they can lose a sense of meaning and a sense of being connected vitally to their life. But depression actually can be treated. It can be treated with psychotherapy. It can be treated with medications. And typically, if depression is treated, the success rate is pretty high. And so if their problem is depression, they may look like they're having dementia because of their cognitive losses. But then that's why you need to assess for depression, because you can treat that, whereas we don't have good treatments for most dementias. And then we've sort of talked about, as you're looking at stages of deterioration in functioning, at some point, the functioning may get pretty severe, and the physician might say, well, we really need to look at what's going on with the brain, in part because we can look at, as we showed in the slides, early Alzheimer's doesn't leave the brain as compromised as middle stage or late stage Alzheimer's. And so we're combining, the practical, how does a person function in the world? We're combining that with functional evaluation with psychology. And then we're also looking at structural imaging with things like MRIs. And sometimes, but MRIs are getting to be used as kind of diagnostic instruments, because you can look at shrinking ventricles or enlarged ventricles. You can look at, and you can also rule out other conditions. A person may be declining because they have a tumor growing in their brain. So it would be important to note, because tumors, well, sometimes where they are, you can't operate on them, but other times, a skilled surgeon can say, I see where the tumor is. We can take out that part of the brain and spare the rest of the brain, and the person might have a pretty substantial recovery. So that's where these different kinds of assessments can play, sort of depending on what stage of disorder a person's in.
Thank you so much, sir, for your time and for your expertise. Our participants have a great feedback, and we'll shortly share with you all these feedbacks. And if there will be any question, we will be posting you.
Yeah, you can certainly, people who have questions, I'd be happy to answer emails that come up. And I think you folks have my email.
Yes, sir. Yes, sir, we have it.
Okay.
Thank you so much, sir.
It's been an honor and a pleasure to talk with you, and hopefully help foster some understanding about this really complex and important area.
Yes, sir, definitely.
Yeah. Well, I hope the rest of the conference goes well for you all. And so I'm going to leave you now then.
Thank you.
Right.
Thank
Bye
you.
now.
Bye. Bye-bye.
Okay, so there we have Dr. Jerry DeVore, and now we have our second speaker, that is Dr. Taqir Ahmed. Dr. Taqir Ahmed is an HOD and Associate Professor of Pharmacology and Neurosciences at National University of Science and Technology, Islamabad. He has obtained his doctorate degree in pharmacology from Aga Khan University. He has an expertise in neuropharmacology and has several publications in the same domain. He was also associated with Riken Brain Science Institute, Japan, as a researcher for a brief period of time. Sir, we welcome you on board.
Thank you so much, Farah. And thank you, organizers, for giving me a chance, for inviting me to this event. I hope I'm audible. Is this okay?
Yes, sir, you are.
Okay. I will now share my screen. I don't know how can I. So this is saying some host disabled participant screen sharing. Can you please enable?
Sir, you can share your screen now.
Okay. Thank you so much, Farah. Just let me know whether it's visible now.
It is visible, sir.
Okay. So I'm also audible?
Yes, you are audible.
Okay. Thank you so much, Farah, once again. And I would like to thank Dr. Sadaf, especially Dr. Sadaf, for the giving me a chance to talk about my research and the organizers. And I have been participating in different sessions. And this school is really going nice. And there are so many different types of lectures from very senior and distinguished professors. And there are, I think, a lot of students from the different parts of the world, as Dr. Sadaf has just now shared that there are so many students with us. So thank you so much once again. I will start, and today's talk title is Dissecting Neuronal Circuitry of Aversive Memory Quantification. So in this short talk, I will talk about the neuronal circuits which are involved in the defining memory strength, particularly aversive memory strength. As you know that aversive memory is extremely important for our day-to-day survival, and same is the case in all animals. So that's why we usually use rodents to study the aversive memory. In this short presentation, I will try to explain the circuit which is involved in the quantification of this memory, how memory strength is defined. I am basically located in Islamabad and currently serving at National University of Sciences and Technology. Before we move on and go to start talking about aversive memories, I thought to share some soft memories and would like to introduce the city where I am. Is actually Islamabad. It's counted in the list of most beautiful capitals around world. So this is a picture I have taken from internet, and you can see Faisal Mosque, which is the signature mosque in Islamabad, close to the Margala Hills. And on the Margala Hills, there's very beautiful road that goes on top of the mountain. And usually people after working hours go on top of the mountain to relax, to enjoy the beautiful view of Islamabad. So most of the participants, international participants, whenever you get chance to visit Pakistan, do avail it and do enjoy the beautiful city of Islamabad. Okay, so this is my location, National University of Sciences and Technology. A bit older picture, but still I thought to show you the overview. It's the whole map is shown here, and this arrow, this arrow is basically the place where we are located, and just across the road is our animal house. Here is our animal house where we do most of the experiments. And as you know that my area of interest is behavioral neuroscience. Okay, now moving to our topic, what are fear memories and which circuitry is involved in fear memories and how are fear memories studied in rodent. I would like to briefly introduce the concept of fear memories, the circuitry, and as well as how it is studied, because I know many students are from different background, and especially this fear conditioning, fear learning, and fear extinction memories, they are a very specialized type of field, and sometimes it is not very easy to understand the concept. So fear memories and the role of amygdala. Whenever we see a snake or any sensory input that is aversive, that is frightening, we generate a response that is known as fearful response, and sometimes that is also known as fire and flight response. So whenever we see a snake, a particular type of like body language is shown, and in this particular response, although there are different brain areas which are involved, but amygdala is the key brain area which plays important role in the generation of fear. And this is the rat brain. A cross section is shown to show you amygdala. And in this amygdala, it is further divided into different nuclei. And the most important are lateral amygdala and the central amygdala. And then there are many other like basolateral amygdala, basomedial amygdala. But in my case, throughout the talk, we will be talking about lateral amygdala, and it is connected to the central amygdala and further how fear response is generated. Okay, another point, how we can study fear learning and fear conditioning, and as I have explained, fear extinction in animals. It's not very difficult to study fear memory in animals, and it has been very well established by different labs around the world. But Joe Lido is the pioneer in amygdala research. He discovered the role of amygdala, and I had chance to work with one of his students, Joshua Johansson, in Riken Brain Science Institute, and it was very nice experience working over there, where we have done most of the project over there. And as I have explained, that in the fear memories, amygdala plays critical role, and how the fear learning and fear memory is studied is shown here. Animal is placed into a box, and this box, there are few lines, like grid lines at the bottom of the box cage, which are used to deliver a foot shock. And aversive stimulus is given. And in this box, there is one auditory speaker, which is used to deliver a sound to the animal. What we really try to do is that on the day of habituation, animal is just placed in this box. And on the day when fear conditioning is done, where animal learns that there is this auditory tone is generating some kind of fearful responses, the auditory tone is given, this is CS for almost 30 seconds. And at the end of this auditory tone, this unconditioned stimulus or a foot shock is given. It means when a tone is delivered, at the end of tone, foot shock is delivered and they are combined. And this is the role of amygdala, that it actually helps us to have associative learning. And on the next day, when the amygdala has formed association between the foot shock and the auditory tone, so when you only give this auditory tone, which is the conditioned stimulus now, animal will show a freezing response. Why freezing response? Freezing is actually a defensive behavior which is shown by animal when they are scared, when they are in the fearful feelings. Okay, so it's very much similar like the Pavlovian classical conditioning experiments, where I hope you have studied the experiments done by the Pavlov on the dogs. So it's very much similar, but only difference is that here we use the foot shock as aversive sensory stimulus. So I have one video to show you how this actually takes place. This is, you can hear the sound. This is a auditory tone. It will be combined with a foot shock. At the end of auditory tone, a foot shock will be given. You can clearly see in this video. Okay, so now you have seen that conditioned stimulus is conditioned, and by this way animal forms 3 or 5 trials are given, animal learns that this box and this stone is fearful, and animal establishes memory, and that's how the model of behavioral learning works. And this is how it was used in the experiments. Okay, so I would also like to explain briefly the circuit of this aversive memory formation before we talk about the experiments, because it is important to know how this like foot shock and CS, they are associated at the amygdala level. Here in this case, this is the amygdala nucleus shown here. Foot shock is given, and CS, auditory tone. Okay, when they are combined, this and through the somatosensory thalamus and auditory thalamus, lateral amygdala is responsible for the association of these two memories coming from these two different pathways. These arrows are basically indicating different pathways coming to the lateral amygdala. And from this lateral amygdala, the message is sent to the central amygdala, which is responsible for the generation of the freezing, increase in blood pressure, and release of the stress hormones, which we call it fire and flight response. So in this periaqueductal gray area from central amygdala to the periaqueductal gray area is also, this pathway is mainly responsible for the generation of freezing response and also the pain. So this is important pathway in the context of our study. So I'm sure now, like all of you are familiar how we can induce fear memories in animals, what is the circuitry involved in this fear memory, and finally, how the experiments are performed. Okay, so now like I will briefly introduce the concept of prediction error coding. Actually, prediction error coding is the concept in which aversive memory strength is defined by the circuit that, as I have explained just now in a moment. So the aversive or fearful experiences powerfully regulate memory formation, and the strength is proportional to the intensity of these experiences. So there are neuronal circuits. I have called them instructive pathways, which are responsible for conveying the aversive signals. If these circuits are inhibited during the time course of prediction by the sensory cues, they set associative memory strength. It means the circuit I have shown you, in that circuit, there are certain instructive pathways, and these instructive pathways, if they are inhibited, the memory strength is defined. But when they are not inhibited, there is different memory strength. When they are inhibited, different memory strength is formed. That is explained here. Aversive event happened, but it was unpredicted, results in formation of strong memory formation. Okay, aversive event happened, but it was predicted. Memory formation, but not as strong as in the above condition. So I can give you an example. I am audible, right? Is everyone with me? Because this is the issue in online meeting. You don't know whether everybody is listening to you. Okay. Okay. So aversive event happened, but it was unpredicted. For example, if you are walking in the street and and a dog comes and suddenly actually it attacks on you, it will result in formation of a memory. However, a second condition is that if you are walking around in the street, a dog comes and it is actually, first of all, it is barking at you and then it attacks. So the fear circuit, the instructive pathways give some sensory cues, and there was some inhibition in the circuit and memory was formed. But this was the second case, memory formation strength is low. This was the first case, unpredicted attack will result in stronger memory formation. Okay, so that was actually explained and proven with the help of experiments. So what is the take-home message from this slide? This phenomena of prediction and on-prediction actually is known as prediction error coding. And there are circuits in the brain that actually define aversive events only activate these instructive with specific events when they occur unpredictably, resulting in elevated memory strength. Okay, so based on these experimental strategies, circuit, and everything, based on the literature, there were a few questions that were in our mind before starting the project. How neuronal circuits construct prediction error signaling during aversive memories? And is this mechanism controlling the strength of associative memories? So keeping in mind these questions, we decided to do the experiments. The same circuit is shown here, and this was based on this circuit. A proposed circuit is shown here. In this case, the aversive input is basically coming into the lateral amygdala. Like we have explained, I have explained you that there are different nuclei in the amygdala, and the important ones are lateral amygdala and central amygdala. And from central amygdala, the connections goes to the periaqueductal gray area. Okay, so this is shown over here as well. So am I audible? Everyone is okay? Can anyone from the audience tell that?
Yes, you are audible.
Okay, good. So I will continue. Okay, that's fine. So that was the proposed circuit. And aversive input comes in to the lateral amygdala, and from the central amygdala, some neurons shown in blue color, they are making connection with the periaqueductal gray area. Remember that this is the pathway that actually is also having some role in the pain. That makes sense because when foot shock is given, role in the role of pain automatically comes in. So first of all, it was the point that central amygdala, we did the experiments to show that central amygdala to ventrolateral periaqueductal gray area circuit regulates prediction error coding in lateral amygdala neurons. So this was the series of first experiments. I will also explain how was the experimental setup. Virus injection expressing inhibitory rhodopsins. What are rhodopsins? I will explain in the next slide briefly, but I can tell you briefly that these are excitatory or inhibitory ion channels. They are usually taken from the bacteria, and they are extensively used in neurosciences. Here in this case, archirhodopsin is basically an inhibitory rhodopsin. Okay, that is expressed, that was injected into the central amygdala, and the recording, this is the recording electrode, was placed in the lateral amygdala, and the laser light was shined in the VL, ventrolateral periaqueductal gray area. So from the animals that were injected with the virus that was expressing the archirhodopsin, which is, as I have told you, is an inhibitory opsin, was expressed in the central amygdala, like you can see in this histological slide. This is lateral amygdala, basolateral amygdala, and this is the central amygdala stained with green fluorescent protein, which is a marker telling that it is properly expressing the required opsin in your cells. And from here, you know that many central amygdala neurons, they are making connection with the periaqueductal gray area. So that's why you can see some green staining in the periaqueductal gray area, or PAG. It means that the virus or the injection system is working. So after that, animals are fixed with the electrodes, and they are connected with the system. Just animation is shown you here, where the electrodes are placed in the lateral amygdala. In this experiment, the target is lateral amygdala, and the laser light system to show green light in the periaqueductal gray area is actually shown here, and it is connected with the laser. And when light is thrown on these cells, they are inhibited. So animals are trained in the fear conditioning task, like I have explained in the beginning. And these were the experimental conditions. Recording neuronal response to the shock. So there was no tone, and there was unpredicted foot shock. This arrow of this arrow is actually telling you the foot shock. Wherever I am using this arrow, it means that the foot shock is delivered, and this arrow is for the condition like auditory tone. So there were 3 conditions shown here. In condition 1, unpredicted foot shock was given. Foot shock was predicted with the help of like auditory tone, and the laser light was turned on. Foot shock was predicted, but the laser light was used to inhibit this circuit, like where this circuit of central amygdala to the periaqueductal gray area. So because the light is being shined, green light is shined on the PAG. Okay, so this was the experimental setup. Just remember 3: unpredicted, predicted, and predicted with laser light. Brief about the excitatory and inhibitory rhodopsin, those who are not familiar. Rhodopsins are basically microbial rhodopsins are light-driven ion pumps, and they are extensively used in neuroscience for light-induced activation or inhibition of neurons. I'm sure most of you, if those who are interested in those options, they know Joe Biden and Paul Diceroth at the Stanford University. Those who were like, those who have major role in discovering these options and role in these options. And I think they were like Richard Seen, they were students from the Richard Seen lab, but now they are so very well characterized that they are being used so extensively. So what is done? Inhibitory virus is injected, and later on, the surgery is done to make possible a tube is passed where the illumination is done on this like group of neurons. For example, there is a neuron here. Okay, when light is thrown on this neuron, this results in inhibition. So these are the experimental setup here. For example, when neuron is firing, this is the action potential shown here. And when the light is thrown, it results in movement of chloride inside, and there is inhibition and there is no firing, stop firing or inhibition. So that's the way actually inhibitory options work, and on the same time, similar is the mechanism for the excitatory options. Okay, so I hope just a reminder slide. This was the experimental setup, and then 3 conditions: unpredicted, predicted, and predicted with laser. Okay, let's see how we got the data. What was the type of data? So this is from the unpredicted, predicted, and predicted plus laser are shown. This is the sign for foot shock, and these are peri-event time histograms, and the raster plots shown on top. These are the raster. These are the peri-event time histogram. I'm sure most of you are familiar. What is peri-event time histogram? This shaded area is telling you when either foot tone was given and the neurons were recorded. This is the time when event started and the neurons are recorded. These are the raw data telling you the number of spikes per second. And on the lower side, you can see z-scores. Z-scores basically tell you the average firing rate and deviation from the average firing rate. So let's see here, in case of unpredicted, when foot shock is given, this is recording from the lateral amygdala neuronal response to the foot shock. Like I've shown you the experimental setup. The lateral amygdala neurons show increase in firing rate here. But in case when the foot shock is predicted, these neurons decrease. There is an increase in firing, but not as much as it was in the unpredicted condition. But when the predicted foot shock along with laser, it means inhibition of the central to ventrolateral PAG pathway is done. The neurons again fire at a high rate. So you can see also the z-scores means increase in firing, slight increase, but not as much as it was in the unpredicted, and again increase in firing rate. So what is the conclusion from this slide or from this set of experiments? Prediction error coding cells, they are shown here and they are like truly representative. These are shock responsive in the unpredicted condition. The red color is showing you the shock responsive cells, percentage shock responsive cells, and they are non-responsive when the foot shock is predicted. On the other hand, when along with prediction, we inhibit the central amygdala to PAG circuit, the shock responsive cells again increase. These again show the shock responsiveness and increase in the shock responsiveness. So it means that these are the pathways which are basically regulating the prediction error coding. And this is just to remind you again, this is a recording from the lateral amygdala. So the next question was, first of all, I will explain this proposed circuit, that aversive input is coming into the lateral amygdala, and from central amygdala to the negative feedback, this was inhibited in previous experiments, and some kind of like inhibition is going on to the lateral amygdala, where you can see, where you remember in the previous slide here, the predicted foot shock resulted in slightly decrease in response. So the next question was whether inhibition of this pathway, when we inhibited this pathway, whether there will be decrease in the lateral amygdala neuron firing or not. Okay, what were the findings? No. So once again, the lateral amygdala neurons were recorded with the help of these electrodes. New surgeries were done, and these scores are shown, where the CS only is shown here, and CS plus laser. You can see that these scores are very much like overlapping in this case, and there is not very much difference in case of when there was inhibition with laser light and when there was no inhibition with laser light, because here there's no inhibition with laser, and here in this case there is inhibition with laser, but there is no difference in the lateral amygdala neurons. So it means that this working model that we proposed, that coming from the central amygdala to PAG and some inhibitory circuit is going on, that is working fine, showing that CS regulated negative feedback pathway from central amygdala to ventrolateral PAG, this blue pathway, and the aversive US pathway, as well as undefined gray pathway. Okay, so if that happens, that is working. So we have to show with the help of behavioral experiments whether when we inhibit this pathway, what will happen to the behavioral responses. If the behavioral responses increase, there is increase in memory formation, increase in memory strength, it means yes, this circuit is really functioning. So keeping in mind, this type of experimental protocol was designed. I'm using pen just for the sake of helping, because it can tell you that where I am focusing on my screen. Okay, on the day one, training was done where the prediction, the condition, auditory tone and foot shock were given for 12 times. And on the day two, test one was performed. And on these group of animals, then they were divided into two different groups. In training two, one group received same amount of training, right? And test two was performed. The other group received slightly increased foot shock intensity and strength and frequency, and again test two was performed. So this is the result from the same foot shock intensity, and this is for the stronger, and test one and test two. It means when the same intensity is kept, right? So the learning strength is not increased, but when we increase the foot shock intensity here in this particular group, which is shown here, the foot shock freezing response is increased, suggesting that increase in foot shock intensity results in increase in memory formation. So the question we asked, how is this possible? And similar types of experiments were done using the opsons, rhodopsins, inhibitory opsins, that probably this type of the central amygdala to ventral neutral VLPAG circuit may be functioned to set the learning strength by inhibiting the shock evoke activation in the feared system. So very similar to this protocol was adopted in behavioral experiments where the virus was injected in the central amygdala and inhibition, laser light, green light, laser light induced inhibition was done in the periaqueductal gray area. But we use different types of controls. So there are three different conditions, 1, 2, and 3. And in condition 1, during the tone and foot shock, laser was turned on, but in this case, only GFP is expressed. No inhibitory opsin is expressed. Inhibitory opsin is expressed here. The laser light is shown on different time, just to show you that if the laser light is shown after the training, whether it function or not, this is kind of like negative control. And this is the real experiment where laser was overlapped during the training, like we have done in the initial series of experiments. So the training protocol is very much similar. Day 1, day 2, test 1, day 3, training again. But in this case, we divided into whether laser on, but GFP, no virus was injected. So no complete virus inhibiting the RHT, only GFP, RHT, but offset and overlap. So these are the behavioral results shown in B, where only GFP group in the test 1 and 2, they showed no significant difference. Offset group, they also showed no significant difference. These dark black colored are the average mean along with SCM standard deviation. And in case of overlap, when this pathway is inhibited, the test 2 results in increase in memory strength. So what does this mean? It means if you inhibit this pathway, it's very much similar, like you increase the intensity of foot shock. And what is the circuit involved from central amygdala to periaqueductal gray area? So further confirmation is done by the pharmacological inhibition, where PBS and mucimol were given to confirm. As you know that PBS is a vehicle and mucimol is GABA blocker. It results in inhibition of neurons that was like injected into the lateral amygdala and central amygdala area. And you can see that this PBS laser on inhibition, again, similar results like this were produced as expected. There was increase in learning, freezing response in the test 2. But when mucimol is given, this effect is blocked. You see here, this effect is blocked. It means, yes, this inhibition, like laser-induced inhibition of the central amygdala to PAG pathway, has resulted in increase in aversive foot shock responsiveness that has actually shown the prediction error coding in the aversive fear memory circuit. Okay, I hope everyone is okay and along with me. So this is confirmation that learning strength is regulated by the feedback circuit of central amygdala to ventrolateral PAG and activation of lateral amygdala neurons. And further, it was shown that the reduced CS processing in the VL neurons after optical inhibition of central amygdala to VL pathway was there. For example, in this case, similarly, the virus was injected here. Laser light was thrown on the PAG, and PAG in this case now, the periaqueductal gray neurons, they are recorded. They are recorded with CS, auditory tone, and then CS plus laser. Okay? So you can see here, initially, the Z-scores are plotted here. based on these two above observations, this observation and this series of experiments, you can see here that these scores are initially they are non-significant, but later on there is slight decrease in the laser. When there is inhibition, there is a slight decrease in the PAG neuron responsiveness. Okay, so now and you can see without laser, those 100% tone responsive cells, and with laser, there are a slight decrease. There are 58% neurons which are not responding to the tone. It means there is slightly decreased in processing at the PAG level. And when we recorded you remember the second set of experiments where lateral amygdala neurons, they showed the same responsiveness, but inhibition of this circuit basically has reduced responsiveness in the PAG area. It means that there is some inhibition. Inhibition of this circuit is playing a crucial role in the prediction error coding. So further confirmation was done whether predictive CS recruits central amygdala, ventrolateral PAG, and RVM pathway to self-learning strength. So based on the literature, it was found that it is already known that PAG, ventrolateral PAG, is connected to rostroventromedial area in the brain. And it is connected to that. And it is also responsible for the pain processing in the real scenario. So first of all, it was in our experiment, we decided to prove that RVM is connected to the PAG. How was done that? A retrograde cholera toxin, you know that cholera toxin has the natural mechanism that it travels through the synapse from one neuron to the another. So the modified cholera toxin B tracer was injected into the RVM as shown here, using the anatomical map. RVM is shown here. And the injection, this bright color injection is shown here. And then tracing or dissections were made from the periaqueductal gray area, VLPAG, periaqueductal gray area. You can clearly see that these shining lights, they are showing those neurons which are connected with the RVM. So this is now established. So in these animals where the tracers are injected, they are trained in very similar behavior like we have explained in day 1 and day 2, where only the box control was shown, immediate shock was given, but after that immediate shock, CS or auditory tone was given, and proper training was done, and then test was recorded. So FOS IR CTB positive. It means that FOS is actually immediate early gene. It is expressed when the neurons are activated. So FOS staining, CTB staining was done. CTB is done because RVM to PAG, if the neuron is connected from RVM to PAG, CTB will be positive. And why FOS? FOS will be positive when the neurons during the training, they are activated, FOS will be expressed. And when you merge and you see that both percent FOS and CTB positive cells, they are highest in case of the training, suggesting that those neurons which are connected with the RVM, they are basically activated when this type of training is done. Just again confirming the circuit from central amygdala to the RVM pathway. So finally, the last set of experiments that I will be talking, that is the retrograde tracers CDM into the RVM, injection of RT into the central amygdala. So the retrograde tracer was injected into the RVM. It will go to the VLPAG, central amygdala. RT injection, those connecting neurons will express in their terminals, they will express the GFAP here in the VLPAG. So those neurons which are connected to the RVM and also connected to the central amygdala, they can be detected here in the PAG. Similar type of training, behavioral experiments in these sets of groups of animals, offset training and laser on overlap. And when we inhibit this circuit, like we have done in the initial experiments, and those connected cells, once again, CFOS positive and CTB positive, collotoxin B positive tracer cells, in the overlap, when we inhibit this pathway, when this pathway was inhibited, there was decrease in the CFOS positive cells. It means those neurons which are actually connected to the coming from the central amygdala to PAG, they are inhibiting. Once again, making sure or confirming that the CFOS is not activated. CFOS activation has decreased in the PAG because we have already shown that the responsiveness, action potential also decreased, responsiveness also decreased, activity also decreased. So completing this circuit, that this is the central amygdala to the PAG, and then again there is inhibitory circuit from negative feedback circuit from PAG to the RVM, and from spinal and trigeminal dorsal horn, probably it goes back to the PAG again and again to the lateral amygdala. So what are the conclusions from this, from this set of experiments, from this study? Learning strength is regulated by the feedback circuit of central amygdala to VLPAG and activation of lateral amygdala neurons. CS processing is reduced in VLPAG neurons with optical inhibition of the central amygdala VLPAG pathway. Fear-induced auditory cues activate a VLPAG RVM pain modulatory circuit that controls memory strength. That is that makes sense because the intensity of the pain is going to modulate the high brain circuit and will also define the memory strength. It is possible that dysregulation of this feedback circuit in humans could lead to the heightened and persistent fear memories leading to the anxiety disorder. So these are the blue colored are the application of this study, that probably this circuit in human beings might be slightly dysregulated. So that if that is dysregulated, that can explain the heightened fear and persistent fear memories and anxiety disorders, PTSD, post-traumatic stress disorders can also be explained with the help of this circuit. This study offers hope for treating anxiety. So that's all from my side. But before I conclude, and I have talked too much about the aversive memories, and to conclude, I would like to conclude on soft memories again, talking about. I would like to show you some pictures from the northern Pakistan. Let me tell you, it's very beautiful area. This is one picture taken from the northern areas, because we are also in the Islamabad is on northern, so we are very much close to the northern areas. It's very beautiful. This place is Jalkhard on the northern areas. I have taken this from the internet, and you can see very nice and beautiful cultural jeep moving on a very beautiful and serene road in the northern areas. Recently, I also had the chance to visit some of those areas, and this is me enjoying cold weather and jeep. And finally, one more very unique thing about northern areas. So you can see here in some areas, you can see a lot of lush green mountains, and some areas, if you go further towards the northern areas in Pakistan and towards the China border. So there is a very unique place in the world located in Pakistan where this is also general knowledge for some students and those who are not from Pakistan, where three world's biggest mountainous ranges, they meet. Himalaya is coming, Karakoram is starting from here, and Hindu Kush is also. So this is the joining place for three the largest range of mountain that is also located in the northern areas in Pakistan. I also had chance to visit. It's very nice place and very unique in the world. Whenever any of you get chance, so do visit this. Thank you so much for your patience and for being here. And thank you so much for once again to the organizers giving me chance to talk about some of the work. And I'll be very happy to answer the questions if you have from students and from anyone. And even if you have any question, you can email me. I can like try to give the answer if I know. You know, I usually say that I am also a student in neurosciences. So I'm like most of you, those who are sitting here, except from the experienced professors. Thank you once again. And thank you very much, Farah and Dr. Sadaf.
Thank you so
That's
much,
all from
sir.
my side.
It was really, really informative talk. Yes, we do have some questions for you. First, from Anna Askari, that is, she wants to ask that were the mice injected bilaterally?
Yeah, they were injected bilateral.
Okay.
Yes, because you
Next, she
know
wants
the
sorry.
amygdala, and we have two amygdala, one on the right side and one on the left side. So there are some studies which are saying the lateralization of amygdala. So that's why we decided to inject on both sides. And then PAG, because most of these connections from the lateral amygdala, they make connection in the PAG. So we recorded from the PAG, which is actually convergence point. Yes.
Okay, sir, another question we have from other mediums. If we inhibit the fear pathway in any organism or animal, what will be the impact of this inhibition on their overall behavior?
I think that's a very good question. And like fear pathway, I usually say, because I've been doing research on this pathway. So fear pathway is also known as the survival pathway. Because if you are not scared of things, it can create problem for you. You will straight away move to your boss room without having fear. You can jump from any like high altitude. You can so fear pathway, inhibition of fear pathway is good to normalize it. But if the fear pathway is already at the normal level, so that is required, that is necessary. Having more fear is not good, that becomes disease. In that condition, you have to treat it, you have to sometimes inhibit. So what you do is that sometimes, you know, the soldiers, after the war is over, they have PTSD. They are usually given treatment that they are allowed to sit in a room, and some sounds of like gun, rifle, war, they are actually exposed to them, so that their PTSD, post-traumatic stress disorder, is treated. So this is one way of treatment. But if you have less than the normal fear, that is also not good. So a balanced amount of fear is very necessary. And it also helps in the formation of memories. For example, when we have bad experience, have the electricity foot shock, and we will remember most of the life that I will not like put my finger into the electric switch again. So that is because of the formation of this circuit and this fear memory. So I hope I have answered the question. If it is not clear, you can I can explain later on.
Sure, sir. Another question Anna has asked that is aversive experience only associated with learning and cognitive adaptation, or something else can be influenced by it?
Actually, aversive experiences do impart some learning. Almost any experience, whether it is aversive, whether it is like nice memory, beautiful memory, everything actually goes to our brain, and later on there is a very nice filtering mechanism in the brain. So those aversive experiences, which are important to remember, they are basically they induce some learning, and mostly the aversive learning is more long lasting. And yes, it results in formation of new memories, and they are stored, and if they are practiced again and again, they become consolidated and they become very strong. And also they modify some circuits. For example, if too much aversive experience is there, once again, the individual can go to the post-traumatic stress disorder, which is not good for the social life, for the personality, and for so many things.
I guess that is it. Okay, we have some more questions.
Yeah. So there are some.
Okay, there's a question from Rujda that if any of the anxiety test was conducted after or can be conducted in order to assess associated anxiety.
Associated anxiety, yeah. For example, anxiety anxiety is actually basically because of so many like group of stimuli, those who are coming from internal, from external environment, and if somebody is exposed to a related stimulus, that individual is already having anxiety from induced from that, so the response, anxiety response, can be higher. There are some like studies on skin conductance, they are done in human beings to study the fear responses, and when any aversive thing is shown, skin response is recorded. And that response can be correlated. If somebody is already like anxiety, is having anxiety too, for example, a few people have plane phobia. If they are like given a condition to sit in a plane, their anxiety response or skin conductance will always tell, okay, yes, this person is already having anxiety. So associated anxiety or any stimulus that is very much like similar to the person having anxiety from, that will induce the response once again. Yeah, definitely. For example, if you go into an interview room and you know that you have already been here and you had some bad experiences here, so next time when you will go into that room again, for example, whether that is the exam hall or interview room, so you will remember that this was the place I had some bad experiences. So your like anxiety or fear responses or fear circuitry will be like stimulated, and some hormones and some like fearful responses will be generated. So the answer is yes.
Okay, thank you so much, sir. We have more questions from Shuja Heather and Asia Afzal, but we are running out of time and our next speaker is waiting. So we will email you these questions. We will email you these questions, and so sorry, participants. We will definitely answer you once we got a response from Dr. Taqi Ahmed. Thank you so much, Dr. Taqi Ahmed.
Thank you, Farah, once again. Thank you so much. Thank you. Thank you so much, participants, for your patience. I will definitely answer all the questions, those who will be sending me. I have like shared my email on my presentation, or you can just Google me, Dr. Taqi Ahmed Nast, and send me your queries. I will try to reply all those queries. Thank you so much once again for your time. Thank you. All the best wishes. I hope you have a good day. I think so Dr. Ubaid Ali is sitting and waiting. Thank you, sir. Nice to see you, and all the best wishes. Thank you so much.
Okay, so our next speaker will be Dr. Ubaid Ali, and he is here with us. Welcome, sir.
Thank you, sir.
Dr. Ubaid Ali is a PhD in pharmaceutical quality sciences who received knowledge through advanced academic and professional courses beside a series of training of regulatory from US FDA Health Canada. He has around about 25-year rich professional hands-on experience and worked on different regulatory agencies' desks as functional head, including pre- and post-registration of drugs, compliance and enforcement of manufacturing facility governing policy, designing initiatives, developing strategies, and conducting training within the regulatory agency. Dr. Ubaid is the Chief Executive of Pharmaceutical Quality and Regulatory Sciences, a division of APRC. He was a consultant of the World Health Organization and other international agencies where he taught regulatory sciences to regulators from different countries. He is aware of the facilities and has seen the manufacturing of biological drugs and vaccines in the United States, Europe, Korea, and China. Got hands-on training experience with the developed world to review and assess the vaccine applications, particularly its quality part, and trained to investigation. Currently, Dr. Ubaid Ali, leading scientific transformation reforms in Drug Regulatory Authority of Pakistan's operation. Sir, we welcome you aboard. Thank you so much.
Thank you. My pleasure. Would you allow me to share screen?
Yes, sir, you can share your screen.
Okay. Hope you will be able to see my screen. Yes.
Sir, you are not audible enough.
Are you able to see my screen?
Yes, we are able to see your screen, but we are unable to hear your voice.
Oh, is it okay now?
Yeah.
Okay. I'll try to speak loudly because probably mic is not performing well. Okay. I really impressed to hear the talk of Mr. Taqir. It was so lovely. It was so scientific and so technical. And it is difficult for me to talk about applied sciences, to applied version of the drugs, which is not equivalent to the deepest science that you people are discussing just before this talk. So let me try to make it easy and make it sensible for me to balance between the molecular level from where you was talking and to the applied level of the drug, what we are experiencing the ground realities. The talk is a therapeutic equivalency on weak chain of sequential trust. And we are manufacturing drugs and delivering the drugs with certain commitment, with some promises. Is it intact or somewhere it is broken? Let me try to compile it. The entire talk is my personal point of view based upon scientific information, which is, of course, which have some authentic references. And I will focus on therapeutic equivalency, new and generic drugs, regulatory review process, and one of the case study of Wellbutrin, which is bupropion, a central nerve acting antidepressant drug. Let's start with what is equal and what is similar. And we have new drug and we have generic drug. All research are being done by the innovator company that brings new drugs, and the follow-on companies or manufacturer of pharmaceuticals or biologicals brought copy drugs that is certainly called generic or biosimilar product. If it is a chemical drug, we say it is a generic product. If it is a biological product, we say it's a biosimilar product. But to determine the similarity and to determine the equivalency in response of with regard of therapeutic values is little complex and difficult process. Let's understand what is placebo, what is nocebo. You know, once we approve drug, we evaluate, all people evaluate the claim. The people evaluate double-blind studies. We evaluate crossover studies. We evaluate multi-centers studies. And these studies are controlled by placebo. And placebo is you people understand, the placebo means it is not drug. It is given with the name of drug, so we can rule out the theoretical value, which is not correlated with the drugs. So placebo is given to balance, to create a difference between the effect of drug and between the effect of placebo that is not drug, but given with the name of the drug. So we can assess the theoretical value of drug or claims. And one is nocebo. Nocebo is just opposite to the placebo. A placebo cannot give any positive effect compared to drugs. If it gives some positive effects, it means your body is reacting with the name of drug and giving some positive effect. And nocebo is another terminology where if you give placebo, it is not drug, but patient is experiencing adverse reactions of that drug, which might possible, and patient was informed through consent, through detailed information about the trial drug, and patient certainly get experiencing that side effects and that adverse effect is called nocebo effect. So in this situation, we have to create a balance between placebo, nocebo, and control drugs. This is just a reality. The total prescriptions generated all around the world, particularly in the US, from where we have collected the data, is 10% is new drugs in terms of value and in terms of volume, and 90% is generic drug. And generic drug are the copy of the new drugs, or even the biosimilar drug, the copy of the biological drugs. The price difference for the new drug and the generic drug, or the new drug and the biosimilar drug, is about 10 to 100. If the new drug is about $100, the generic drug is about $10. And what is the ultimate objective of regulatory authority or the company or the sponsor? To prove that your drug is safe, relatively safe. Nothing is absolutely safe. It should be relatively safe. It is efficacious. It is of quality. Means it is safe for your liver. It is safe for your kidney. It is safe for your brain. It is safe for your heart. It is safe from teratogenic effect or similar other irreversible damages. And efficacious, what we are saying, what we are claiming, it is effective. It is not placebo effect. It may not generate nocebo effect. It is effective against the particular claim that we are generating. And it is quality. Company is capable to manufacture same drug time after time, batch after batch, every tablet, every injection, or every unit with same amount of drug, with same pattern of release, with similar time, in similar time with same profile, is a quality drugs. So we have a clinical trial is a huge exercise, required lots of money to generate clinical trial data, and require human resources or human volunteers too for generating the clinical data. So in case of new drug, you can see, just let me allow to share highlight, share pan. In case of a new drug, all clinical studies has been done, while in generic, not in biosimilar, but in generic, we just connect all the data with generic through a release pattern studies. And what it is, I'll talk later. You can see, once you see a new drug in market, the previous information or previous work is the laboratory data. There is a concept. On the basis of the concept, you generate laboratory data to prove your as a proof of your concept. After generating the laboratory data, you conduct a trial on animal to generate animal data in real time. After generating the animal data where safety, where dose, where certain efficacy, you determine, you enter in phase 1 clinical trial. Phase 1 clinical trial is restricted to few people. It's not more than 2 to 5 or 10, in which you conduct safety study. Although you have all the informations, all the calculations with you to determine or to say that your drug is safe, but before entering in the human body, you need to conduct phase 1 clinical trial on limited human bodies. After phase 1 trial, once you get good results or favorable results in terms of safety, you enter for larger, bigger trial that's called phase 2 trial, where you determine safety or generate data to support safety, and again to see the efficacy of the drug that is you are claiming. After phase 2 trial, you enter into phase 3 trial. Is a larger multi-center randomized control trials where you generate supportive data for efficacy and safety. After these 3 trials, phase 1, phase 2, and phase 3, done on human being, you apply to the government for its approval, and regulatory authority screen your data, regulatory authority assess your data, review your data, and evaluate your data to get it comments whether it is approved or you need to have some certain question to respond. This is called complete response letter. You get approved drug from here after phase 3 trial, and after some time when patent expires or exclusivity rights and the generic drugs comes in, and the light green is here for generic drug. And generic drug, if you see generic drug, where we see just release pattern. Release pattern means concentration and concentration profile with respect to time and with respect to a particular dosage family. We rely on these release pattern, all these clinical studies as a relative calculation, under relative calculation. Although phase 4 trial is continued till sufficient amount of data or post-marketing studies and vigilance continued throughout the life cycle, and this phase 4 trial or post-marketing surveillance of quality studies or even vigilance studies is continued in generic drug as well. So generic drug, 90% of the volume is consumed. The 90% drug consumed are generics or biosimilar. So the generics drugs, we need to see the substance, an active pharmaceutical ingredient, whether it is a biological or chemical, the product, the finished product, the process where it is manufactured, whether it is a substance or the product, which process it is manufactured, facilities where it is manufactured, what was the HVAC, heat ventilation air conditioning system, what was the equipment system, what was the qualification system of the equipment, what was the cleaning system, what was the human resource, and so on. Microbiology, where it is required in injectable product. Microbiology is critical in biological product where microbial potential, where microorganism can interfere in the biological activity is very important. Biopharmaceutics, how drug act with the biology and biology react with the drug is biopharmaceutics, and it is very important to see once we are approving or assessing the generic products. So generic product has 4 different important issues. Is the CMC, is chemistry, manufacturing and control, chemistry of the substance, chemistry of the product, and manufacturing of the process, control of the facilities, control of the microbials, biopharmaceuticals affairs, and the certain is biostudies. For biostudies, we go for biopharmaceutical to create a relevance with all clinical studies done by the innovator, that is phase 1, phase 2, phase 3. So we conduct release studies under biostudies or certain different in vitro studies to link a relationship or to build a relationship with innovator product. GMP is a good manufacturing practices, how you manufacture drug in the manufacturing facilities, and how you control the process, how you ensure that your product which you are going to manufacture is consistent throughout the batch after batch, and time after time for each product, and how it is stable throughout the shelf life that is declared by you, what studies you have done is important in the GMP. GMP, a big subject where a lot of different topics cover and comes in. Promise, what is your label? A generic manufacturer cannot change promise or cannot change claim that is approved for the innovator product, because innovator has done the clinical studies, and upon the results of the clinical studies, real-time information, they generated the promise. They argue, they justify their promise. So label talks about the promise. So generic manufacturer cannot change the promise which is approved by the authority for the innovator. They cannot add. So to build the clinical relevance, first is chemistry. Chemistry is very important up to the molecular level. What is the physical chemistry and what is the organic chemistry here in with the molecules? And after the chemistry of drug substance or different excipients or different materials that comes into contact during the manufacturing process, after studying the chemistry of all these affairs, we enter into pharmaceutical equivalency. That means all the raw materials, all the excipients, all the active pharmaceutical ingredients, their quality and their salts. After pharmaceutical equivalency, we need to determine the bioequivalence. Bioequivalence means studies inside the biological systems. And after bioequivalence, you can say if that is your product. If your product is bioequivalent, or if it means you manufactured a generic product and compared to the innovator product, you identify certain individuals, you administer innovator product and develop a profile, means concentration level of a drug inside the biological systems with respect to time. You develop a profile. This profile is a curve. First is absorption rate, other again is distribution, elimination, and metabolism rate. And this curve is called biostudies. And this curve, under the curve, we identify the area that is below the curve, is called area under the curve. You develop a, let me draw it like this. This is called area under the curve. This all the called area under the curve. And this is called Cmax, generic product inside the biological system, and compare both profile each other with innovator drug profile and generic drug profile in same biological system of same individual. So if the area under the curve, Cmax, maximum concentration, and Tmax are comparable, we may say it is a bioequivalent product. Expectations of the clinical promises. So pharmaceutical equivalence means if product, we talk about the chemistry of everything. Is a drug substance? Is it excipients? Is a drug product? Is a material where it is come in contact throughout the manufacturing process or its storage? Is called chemistry. Then after chemistry, we see the pharmaceutical equivalence means the same active ingredient in same dosage form. It means if it is a tablet, the generic will be tablet. Generic may not be a syrup. If it is a syrup, generic may not be a suspension. It will be a syrup. If it is a solution, generic will be a solution. So we cannot change the dosage form. Route of administration, if drug is a intravenous, you may not change to intramuscular. If drug is a oral, you may not change to sublingual. The generic will follow the same route of administration on which innovator drug or reference drug is approved, because clinical studies is done on the reference drug, not on the generic drug. Its strength. If it is 250 milligram, it means it is 250 milligram, no more, no less. It's the same quality. It has ability to produce with same consistent manner, with same potency, with same shelf life. Purity. It should be relatively pure without any impurity. If some impurity is there, it should be within the limit that is set for the purpose, and we must identify the level of impurity, and somehow we need to characterize the name of impurity so we can see their teratogenic potential or their carcinogenic potential we can assess. In any case, the limit is set. You may not elevate the impurity level up to the above the limit that is set for the purpose. Allowable difference. A generic drug may differ with term to shape, but it is not encouraging to change the shape, because a patient who has a psychiatric disorder does not believe, and even the patient individuals who believes on drugs may not be comfortable if you change the shape. Scoring, you can change the scoring. You may add a score or you may remove a score, but it is allowable, but it's not encouraging. Release mechanism. Somehow release mechanism, there is some differences. You have a limit. You can change within the limit. You may not go outside the limit. Excipient and packaging material, you may change excipients, but the excipients you are using must not be out of the list that is approved, called inactive ingredient guide list. You may not go beyond the limit. You may not add any excipient which is not included in this guide. You may change the packaging depending upon your own stability studies. You may change the shelf life. If it is an innovator says it is a 2-year shelf life, you may go for 3 years. You may go for 1.5 years, but it will depend upon your studies. Clinical relevance. A generic drug that is both bio and pharmaceutical equivalent must also act in the same clinical relevant way. That include duration of use, indications, and target populations. PK is pharmacokinetic and PD is pharmacodynamics. Pharmacokinetics means behavior of the body with the drug, and pharmacodynamics means behavior of the drug with the body. Endpoint, in clinical endpoint, what is the ultimate endpoint? Markers, biological markers, or certain markers are qualified, like endorphin markers, and different markers are qualified to establish suitability for clinical relevance. These points are determined to study the clinical relevance. Biopharmaceutical evaluation affair, from fiction to reality. So performance should be the same way. If you are manufacturing generic product, the performance should be the same way, no worse, no better. We will not expect better way for generic product. You have to follow the innovator product, because again, all the clinical studies on which drug is standing in the market is done by innovator company. So bioequivalency are not the clinical studies. If you perform bioequivalence studies or release pattern studies, it's not clinical studies. Nothing to do with the safety. This studies does not talk about the safety or efficacy of the molecule or inherent issues of the molecule with regard to safety and efficacy. This is just evaluating the similarity of trend and kinetics. That's it. Pharmaceutical equivalent and bioequivalent. We discuss about the pharmaceutical equivalents, means the same molecule, same salt, with same route in same amount. Bioequivalent, it is proven with the reference product inside the biological system of same individual, that is crossover studies with adequate time period, and the area under the curve, Cmax and Tmax, are relatively similar and comparable. Pharmaceutical equivalence, we determine it is required. The drug may not be, should be or must be pharmaceutical equivalence if it is a candidate for bioequivalent. And if your drug is bioequivalent, it may consider as a therapeutical equivalent, and therapeutical equivalency maybe you can go for similar therapeutical equivalency, but we have a case where therapeutical equivalency is challenged. Does not mean equivalent performance. If your drug is bioequivalent, if your drug is pharmaceutical equivalence, it doesn't mean every time it will give same clinical performance. So biopharmaceutical classification system means if your drug, your substance is highly soluble, highly permeable, it may be highly soluble, less permeable, it is a less soluble, less permeable, it's a less soluble and high permeable. This solubility and this permeability has a greater role in absorption of drug, in distribution of drug, in metabolism of drug, and in elimination of drug. It means these solubility and permeability has impact on the blood profiling of drug that is required to relate with the clinical studies or to develop relevance with the clinical studies done by the innovator. Let's see, if you are manufacturing injectable drugs, same qualitatively and quantitatively, same quality material you are using, same quantity you are using, Evidence of in vitro studies, formulation, manufacturing process available. Does biostudy required? Waiver, there is no required. If you are manufacturing injectable drug, we know the quality, we know the quantity of the active pharmaceutical ingredient is same, and it is a water-soluble formulation. You have to administer inside the intravenous, inside the biological system. There is no need to go for bioequivalence studies because the profile will be the same. In oral solution with different excipients, X company is using different excipient and Y is different excipient, but within the approved guidelines, that is inactive ingredient guidelines, within the limit, biostudy is required? No, it's a waiver. You are, let's take an example. You are solubilizing glucose of company X, you're solubilizing glucose of company Y. There is no need, because glucose is soluble in water, there is no need to conduct biology studies to see whether glucose reaches to the blood or not. It will reach to the blood. There is no conclusive evidence that that it may resist or that may ask for biostudies. Oral solution with different excipient. If you are changing the excipients or inactive ingredient, biostudies required. Impact of absorption or safety needs to be demonstrated. We are not asking about the biostudies, but you need to calculate, you need to justify that this excipient will not impact on the absorption of drug, and ultimately, if it will not impact, it will not create any safety issue. Let's this is a high time. Let's crystallize the discussion. New drugs is new molecule entity, new formulation of the previously approved drug, new combination of 2 or more approved drug, new indication for already marketed drug. So new formulation means if you are, it is not new drug, new molecule, but you are developing new formulation. Suppose it was intravenous drug and now you are manufacturing a transdermal drug. It is a new formulation. It will consider as a new drug. New drug, innovative, non-clinical data, clinical data, product development is required. All these studies about the all the clinical studies, all the product developmental studies, laboratory studies needs to be submitted to the government. The government or the regulatory authority screen, assess, review, and evaluate to understand safety, efficacy, and quality of drugs. Protection and of promise and label claim as the shared responsibility of the government, like FDA or the company, both will share the responsibility. Bioequivalence, it means a generic. If a chemical, it is a generic. No need for animal studies, no need for clinical studies, no need for biology studies in some cases. Generic required chemistry, manufacturing controls, manufacturing processes, testing, labeling, and inspections. Generic drugs, this may be a red apple, may be an innovator drug, but all 3 apple are the similar drug. If you cut into the pieces, there is no difference between the generic drug on the similar and the innovator drug. There's absolutely no differences. Relation between new drugs and generic drugs, biostudies of generic are surrogate for all clinical studies done by the innovator. So let's take an example, and that is sometime mass, sometime models does not favor. It is a case of bupropion, which is an antidepressant drug study on low dose. Because if you have high dose and you have low dose, we may not allow to go for high dose due to it may put risk to the volunteers who are taking part in biostudies. So in order to avoid unreasonable risk, we ask for low dose to conduct biology studies because the proportionality of the tablet or the composition of the materials are similar for low dose and for high dose. That's why if drugs is qualified on low dose, we may give waiver as a matter of policy, as a matter of guidance, as a matter of regulations for high dose. What happened by bupropion case, this is Velbutrin, as a failure. Desired candidate was not achieved. Antiva was the company who are manufacturing and distributing the drug. FDA asked to stop distribution in September 2012. Just to make it summary, bupropion, IR means immediate release tablet of SKB SmithKline Beecham, that is now GSK, in 1985. Bupropion SR means sustained release tablet. sustained release tablet in 1996 that was approved after the patent expiry as Excel tablet, long-acting tablet in 2003, based on evidence demonstrating bioequivalence with low strength. It was done in 2006. Generic version manufactured by Impex, marketed by Teva, was approved. 85 post-marketing reports from January to June 2007 was received by the FDA or in different portfolio. Experience undesirable effects. Sometimes it is reported that the patient are not getting same therapeutic response that he was used to experience with the innovator drugs. Increased side effects, decreased therapeutic effects, and people get research to on innovator brands. Temporal relationship under questions. Although drug was approved by the FDA re-examined bioequivalence studies, conduct studies for 300 milligram long-acting drug, and FDA concluded, and the company himself concluded that the difference of 300 milligram innovator and the generic was significant. Withdrawal of Teva drug in 2013 against September 2012 FDA advice. Also, generic of Actavis withdraw their version, a new challenge. Other generics will rule out not work always, because it's a life. You have to calculate, you have to determine that every formula may not every time suitable for every product or for every strength. So we need to be careful and to understand and get insight by taking a dive in deeper science to understand cause-effect relationship, what was the reason, and how do you connect the different dots. Thank you very much for understanding, for being with us. Thank you.
Thank you so much, sir. That was really informative. And as usual, we learned a lot from you. We have some questions.
Sure, please.
Okay, Joshua Wilson wants to ask you, to what extent organoids can be used for drug clinical trials instead of human volunteers?
Sorry, may I ask again, what?
To what extent organoids can be used for drug clinical trials instead of human volunteers?
No, let me be very clear. Clinical trials means...
Sir, you need to speak a little louder.
Okay, let me be very clear. The clinical trials means trial on human being, not any models. Animal studies may not be replicator of human being. Hello?
Yes, sir, you're audible.
Okay, what I was saying, that clinical trial may not conducted or may not be changed with the animal data. You need to verify your animal data on human being. There is no substitute.
Sir?
Is it? Yes, Farah?
Yes. Yes, sir, you're audible. Yeah, you can continue.
I have completed my answer, because animal studies may not be substitute for the human study.
Sir, we have another question from Anna Askari. As opioid use disorder exists everywhere in the world, are there any requirements on opioid and controlled substances prescribing for doctors? If yes, why is the disorder increasing?
Sorry, may I ask, please read again?
Sure, sir. As opioid use disorder exists everywhere in the world, are there any requirements on opioid and controlled substances prescribing for doctors? If yes, why is the disorder increases?
You know, once we impose any restrictions, people get offended. And opioid is opioid analgesics. All opioid analgesics are comes under narcotic control. So in order to avoid its misuse, or rather abuse, we need some control. And once we place some control, bad elements comes in the market all over the world. This is the universal phenomena, and capture the market underground. So that's the reason. But continuously, the regulatory authority, even in the US, you just see the Johnson & Johnson case, you just see the recent cases of misuse of the drug for narcotic drug. A regulatory authority is vigilant all over the world, but the same is happening, what you are saying.
Okay, sir, we have another question from different mediums. There are cannabis use, because use of cannabis. There are certain countries in the world that where cannabis has made legal for the use for common people. What are the consequences of this? And especially in a country like Pakistan, how do you see a clinical trial on such drugs?
You know, the control level of the Pakistan and the control level of the US may not be comparable. So Pakistan needs to be very careful while approving cannabis or any drug. We may not deny the effect of cannabis. We may not stop the legitimate use of cannabis. So Pakistan is in process to develop a strategy for approval of cannabis with certain control. And of course, this control will be more stringent than the US because of flexibility and the weakness of the door available here in Pakistan.
Okay, sir, another participant has asked, how many clinical trials are being run by the Pakistani people, actually, their contribution to such clinical trials?
You know, clinical trials are three different types or phases: phase 1, phase 2, and phase 3. To conduct phase 1 trial is too difficult and too critical. So we may not allow phase 1 clinical trial here in Pakistan unless it is safe, unless it may not create unreasonable threat to the subject. However, at this time, dozens of clinical trials are underway in Pakistan, particularly phase 3 clinical trials are underway. And I know 2 or 3 is a phase 2 clinical trial is approved here in Pakistan.
Okay. We have another question from Sandeep. What medications reduce the effectiveness of oral contraceptives?
Oh, is a pharmacy. It's a question for a pharmacist or for a physician who is practicing. I may not comment. There's a list of products which maybe you may go Google with any drug information, related drug information.
Sure, sir. Do we have other questions? Okay, I guess that is it, sir. Thank you so much. Your talk was as informative as it was always. Thank you. Thank you. So nice to have you.
Thank you, sir. Thank you very much for listening. Thank you.
Okay, participants, we will now have a lab tutorial of Dr. Saima Kul after a short break. This is 12:15. After exact 30 minutes, we will rejoin this session and we will continue. Thank you. Welcome back, everyone. We've heard our speakers. Now it's the time for the lab tutorial that is being conducted by Dr. Saima Gul and Roxana Nawaz. Dr. Saima Gul has completed her PhD research on effect of antioxidant and anti-platelet activity on plants and their signals transduction from the University of Karachi, Pakistan. Continued her postdoctoral training at Timing, Memory and Decision Making Lab, Department of Psychology, KOC University, University Istanbul. She has been working on behavioral psychology, pharmacology, molecular biology, and neuroscience. She is an assistant professor at the Department of Physical Therapy, Shifa Tamir Millat University, Islamabad. Dr. Saima is an active member of IBRO, Pakistan Society of Basic and Applied Neurosciences, Pakistan, and Women in World Neuroscience Society, Pakistan. We also have Dr. Roxana Nawaz, who has completed her PhD in molecular medicines, neurogenetics, from the International Center of Chemical and Biological Sciences, ICBS, University of Karachi, Pakistan, in 2013. Her PhD thesis focuses on the genetic profile of schizophrenic patients in Pakistan. She was affiliated with the Department of Molecular Pathology at Dow University of Health Sciences as an assistant professor. In 2015, Dr. Roxana moved to UAE to pursue her postdoc in the Behavioral Neuroscience Lab. Currently, she is working as a research specialist in Behavioral Neuroscience Laboratory at the United Arab Emirates University. So we will play their video first, and then Dr. Saima Gul will be live for your question answer session.
Thank you so much. Hello, everyone. Welcome to IBRO Asia Pacific Regional Committee School of Neuroscience, Pakistan. This is Saima Gul. Today, I am here to conduct online lab tutorial, which based on neurodegenerative research model in the laboratories. Dr. Roxana Nawaz is also sharing today's lab tutorial with me, and she will continue hands-on lab session after this presentation. Before I start, I myself and Dr. Roxana would like to thank the organizer of this workshop and conference in Karachi, and special thanks to Dr. Sadaf Ahmed, chief organizer, for the most wonderful and informative conference in this region. Now we'll start the presentation. The topic of today's presentation is neurodegenerative diseases, research model mechanism, and advanced therapeutic strategies. So before to move next, here are some here are the topics of this presentation that I will discuss in the rest of this presentation. So these are basically the highlights of the presentation. Okay, so before we go too deep in detail, I want to give you a clear concept about the word neurodegeneration and neuroregeneration. So what are their meaning? So degeneration means change from a higher to a lower form. You can say degeneration means neurodegenerative means involving degeneration. So neurodegenerative diseases is an umbrella term for a range of conditions which primarily affect the neurons in the human brain. And as you know, that neurons are the building blocks of the nervous system, which includes the brain and spinal cord. So neurons normally do not reproduce or replace themselves. So when they become damaged or die, they cannot be replaced by the body. So if we see the history, of neurodegenerative diseases, we came to know that the term degeneration was used in the 18th century to explain the variability in the human race. And before and during World War II, a 19th century hypothesis about the degeneration of human beings became related to increasing, like you say, gruesome events. And after World War II, the term degeneration disappeared from genetics and psychiatry, but survived to denote decay of cells and structure. The label this neurodegenerative become common for a category of central nervous system disorders. So the history of neurodegenerative diseases is the history of progress, basically. This is the history of past, you can say, great doctors and scientists making great doctors and scientists for the present. So first time the word neurodegeneration was identified by Pinel in 1816. Later, after a year in 1817, Dr. James described Parkinson disease as a medical syndrome. So up to the first half of the 19th century, historical notions regarding dementias were like relatively scanty. But this simplest theory of the purely has begun actually rise in Germany and in Alzheimer, that is like in 1907. So since then, the histopathological study of the senile brain was the object of several contribution. And in current era, the Medical Research Council states in a strategic review that neurodegenerative diseases are strongly linked with age, which result in progressive decline or death of neurons. So they include like Parkinson disease, Alzheimer disease, and other dementias, Huntington's disease, and multiple sclerosis. So in another in 2012, the European Joint Program launched a research strategy in their executive summary that neurodegenerative diseases are characterized as largely untreatable conditions that are strongly linked with age. So this is the history. Okay, now this picture will give you explanation about what happened in the brain when person suffer with neurodegenerative diseases. So these are some brain regions that affected by Alzheimer, Huntington's, and Parkinson's disease. So region like in color of the sagittal sections are those that are affected by disease. So the region in gray are those that are affected to a lesser extent or at later disease stage. So you can see here the upward arrow, which show the increased level down. There is like this downward arrows show decreased level, and the left right show like indicate no change in the level of these cholesterol. You can see here in this orange, or this 24HC, this is hydroxycholesterol in green, and CYP, cytochrome 460, that is in this where is it? Yeah, here in magenta color. So these are in different region of these disease affected brain. So basically, the development of neurodegenerative is influenced by several events, among which the dysregulation of cholesterol metabolism in the brain plays a major role. And maintenance of brain cholesterol homeostasis is essential for neuronal functioning and brain development. So the level of this sterol were slightly increased in the plasma of patient with early AD and non-AD demented patient, and conversely, patient with advanced AD had decreased this hydroxycholesterol, 24 hydroxycholesterol level in their plasma. And you can see in this figure, it reflecting the marked destruction of the CNS and hence the reduction in the CYP 46A level in the flux of 24-HC hydroxycholesterol region. If you measure this 24-HC in this 4 region, in the frontal, occipital cortices, basal ganglia and pons of patient with AD, it will decrease sterol level in all 4 regions and close coupling between cholesterol biosynthesis and elimination. Okay, so if we see the overall pathophysiology of neurodegenerative diseases, so this diagram showing the role of activated astrocytes, microglia, neuroinflammation, and elevated oxidative stress in the process of neurodegeneration. So as I'm continuously focusing on the word of neurodegeneration, that is used for several neurological disorder, like Alzheimer, Parkinson, Huntington's, and ALS, that is amyotrophic lateral sclerosis. So there are various pathophysiological bases of neurodegenerative diseases, but the most important are accumulation of abnormal proteins, oxidative stress in neuroinflammation, and mitochondrial dysfunction. So this figure is showing the progression of neurodegenerative diseases and the role of different factors. Here you can see in this figure show that the oxidative stress and neuroinflammation are the initiator of neurodegenerative disorder. So oxidative stress is produced from various factors, like the accumulation of abnormal proteins, disturbance in the balance of peroxidation and unsaturated fatty acids, and you can say the high trafficking of calcium across the neurons. So these elevated oxidative stress can activate several biochemical pathways that induce oxidative damage of other molecules like lipid, protein, and DNA, and leading to the neuronal cell death, like you can say apoptosis and neurodegeneration, and which is obviously ultimately lead to cognitive and memory dysfunction. Okay, so now as I told that neuroinflammation is also the initiator of neurodegeneration. So neuroinflammation is the, you can say, inflammation of the central nervous system, because its name applies like neuroinflammation. So this is basically the inflammation of the central nervous system and is due to a complex immune response of the brain to injury. So that leading to the activation of the glial cells and release of inflammatory cytokines, causing serious consequences that is related to the neurodegenerative disease. And on side by side, it causes effect on the different pre and post synaptic markers. You can see here in this picture, like PSD 95, which associated with distinct brain diseases that lead to cognitive and memory dysfunction. So apart from this pathophysiology of neurodegeneration, neuronal death also linked to misfolded protein that aggregate within the brain, like proteins or proteinopathies. occur. So this aggregate within the brain as a result of disease-related gene mutation or abnormal protein homeostasis occur. So as we know that there are two major degradation pathways to rid a cell of unwanted or misfolded protein to prevent their accumulation and to maintain the health of cell. One is the ubiquitin proteasome system and the autophagy lysosomal pathway. So both degradative pathway depends on the modification of targets with ubiquitin. And aging is the primary risk factor of most neurodegenerative diseases, include Alzheimer's, Alzheimer's disease and Parkinson's and amyotrophic laterosclerosis. So with aging, reduction in proteasomal degradation and autophagy and consequent this increase of protein neurotoxic protein aggregate like this potentially neurotoxic protein aggregates of you can say beta amyloid and tau alpha synuclein and superoxide dismutase and TDP43, that is TAR DNA binding protein. So aggregated proteins disturb the signaling pathway, which can be critical for homeostatic mechanism. So, and this is the fundamental of for neuronal function and survival. So research needs the role of ubiquitin-dependent processes in the progressive loss of neurons and the emergence of ubiquitin signaling as a target for the development of new drug to treat neurodegenerative diseases. So this is the okay. So basically the nature of long-lived nature of neuronal cell and their inability to undergo division predisposes them to the toxic effect of accumulated misfolded protein or damage organelle. So this diagram shows the degradation dependent and degradation independent ubiquitin signaling, which play a fundamental role in neuronal functioning and survival, and disrupted control of these processes can trigger the neuronal loss. So defective clearance of ubiquitinated protein aggregates such as amyloid beta, tau, these are in ADs, alpha-synucleins in PD, and Huntington protein, this is in Huntington disease, superoxide dismutase or TAR DNA binding protein TDP43 in ALS. So these protein aggregates or these misfolded ubiquitinated protein aggregates due to impaired proteasomal degradation and or you can say impaired autophagy lysosomal, maybe like impaired proteasomal degradation and impaired autophagal lysosomal degradation. These are the hallmark of neurodegenerative diseases. So you can see in this diagram as well. So you can see here the pathological effect of defective mitochondria that is exacerbated by impaired ubiquitin mediated mitophagy due to the compromised this pink one or E3 ubiquitin ligase parking. So damaged mitochondria are a potent source of damaging reactive oxygen species. So here in this picture, you can see the toxic protein aggregate, mitochondrial DNA and myelin deposit trigger the neuroinflammasome formation and the release of pro-inflammatory cytokines such as interleukin 1, interleukin 1-8, and other neurotoxic factor by reactive astrocytes and these microglia. And you can see here the disturbed ubiquitin signaling in the DNA damage response via ubiquitin, ubiquitination of histones. So this dysregulated receptor trafficking here endosomal trafficking such as the mediated by NDD4 regulates cell surface expression of key neuronal receptor including EGF and AMPA receptors. So you can say defects in the ubiquitin regulated pathway are the emerging as important you can say driver of neurodegenerative disease. So in this slide, okay, I hope I'm not boring you. Okay, so now in this slide, I will explain you the types of neurodegenerative diseases. What are these types and why we have classified them. So basically, neurodegenerative diseases share some common pathological markers, that is accumulation of these characteristics proteins into insoluble aggregates within or between neurons, along with cell dysfunction and ultimately neuronal death. So the majority of neurodegenerative diseases are clinically heterogeneous and genetically complex. Alzheimer's disease and Parkinson's disease, in which more than 90% of cases are not linked to a single mutation. And it here you can I think I must be mentioning that the Huntington disease is a purely genetic disorder. So these neurodegenerative disorders share, you can say, common clinical feature, including the clinical course and molecular mechanism of pathogenesis. And neurodegenerative diseases also share some like these pathological hallmark, like these the aggregates, misfolded proteins, and within and in between neurons, and along with the synaptic loss and neuronal death. So these proteins include alpha-synuclein of Levy bodies and Levy neurites in Parkinson's disease in PD patients, beta amyloid of senile plaques, and tau of neurofibrillary links in AD, polyglutamine rich Huntington inclusion in the Huntington disease, and this TDP 43 aggregates and tau in the FTD. This is frontotemporal dementia. Like you can say, so far there is no treatment this capable of modifying the course of neurodegenerative diseases. So the identification of effective drug depends on the underlying of the pathophysiological mechanism which are underlying each disease. So one step into this direction depends on the availability of animal models that can mimic the neuropathological and clinical features of each neurodegenerative disease. So now we are moving to see what are the research models used for neurodegenerative disease. But first, we need to know what is model, what is its purpose, and how these model validated. So research model is actually the any experimental preparation that is developed for the purpose of studying a condition in the same or different species. And typically models are preparation in animals that attempt to mimic human condition. And the purpose of you can say making model is to also mimic the syndrome in its entirety. But it is difficult if your knowledge of the syndrome is incomplete and changing. So one purpose of making model to study potential therapeutic treatment and their effective dose to identify the new drug with novel mechanism of action. And the purpose of making models could be the mimic only specific sign and symptoms, but symptoms being, you can say, modeled may not be diagnostic for the disorder, but should be reliably measured and defined. This is basically useful for study that involve both patients and product models. So if we see the model validation, so models are only as sound as the information currently available in the clinical literature. So model assume a common basis for the behavior and physiology of various species. And models should be reliable in terms of induction and outcome. So variable cannot be like always be considered like you can say an error. So these are the, you can say, you can make up. Okay, so these are the current model expert who work in vivo and in vitro models, and their main objective to follow the models are in drug screening, to investigate the pathophysiology of disease and to identify the novel biomarker. And scientists have used animal models in research since the ancient Greek era. For example, Alcmaeon of Croton studied the brain within brain of dog now. So studied the brain with dogs in the 6th century BC. So since then, many different models have been used for different application, like nematode, C. elegans, and here this fly, Drosophila. The complete name is, what is this? Drosophila melanogaster. Drosophila melanogaster, zebrafish, frog, xenopus, mouse, rat, rabbit, dog, and primates, rhesus macaque. So these are some examples of models that have been used and which are still used today in research. So here in this picture, you can see some models and their advantages, like okay, why scientists used as a model. And here these are the some indexing, like PubMed index publication regarding these animal models. So the importance of animal disease model has changed drastically in the last decade, and last decade, and because the identification of disease genes has allowed the creation of new model. So transgenic animals expressing the human mutant gene have been created, as have model in which the animal endogenous disease associated gene has been mutated. In the past decade, molecular twists have been used to create transgenic model in which the transgene can be turned on and turned off. and even extensive selective expressed in only a certain neurons. So knock-in and knockout models of genetic defects has also been made. So in the genetic era, there are cell like yeast, fly, this Drosophila, and worm, C. elegans. These models of neurodegenerative disease they use in this genetic era. So most like recently to study apart from this these models. So most recently the study of more sophisticated transgenic model of Huntington disease use sheep, pig, and primate model. They like studies in studies these models have been made. So these animal models have proved to be a powerful tool for studying the biology underlying the disease process. Okay, so now in next few slides, I will discuss different research models that use for different neurodegenerative diseases. These are some models for Parkinson disease. Parkinson disease, as you know, the second most common neurodegenerative diseases, and prevalence varies from 1 to 4% in people over 60 years. So neuropathological hallmark of PD are the loss of dopaminergic neurons in the substantia nigra, pars compacta, and the formation of intraneuronal proteinaceous inclusion that is called as Lewy bodies in the affected brain areas. So these Lewy bodies are composed of unbranched alpha-synuclein filaments and ubiquitin, and most likely result from ineffective protein degradation. And there are genetic and neurotoxin-based model of PD. Either toxic or genetic based model have their own advantages and disadvantages. Here I some advantages and disadvantages summarized. So genetic basis for several form of PD are related to Parkinsonian disorder, and that has been elucidated in the past 2 decades. And genetic models of diseases usually can be made of a mutant gene involved in the development of disease, and or a gene that might not be validated in the disease but can recapitulate some key feature of the disease in the model system. So here are the 5 genes that are frequently used, frequently targeted as disease model for this PD, and they all have been associated with familial Parkinson disease. So these 5 diseases you can see in this picture. And advantages of, if you see, the advantages of these models include after this model is there is a decreases dopamine release in the striatum, motor impairment occur in this model, and behavioral deficit include, and mitochondrial dysfunction also seen in this model. But side by side there is some disadvantages also of this model, like some models are not show loss of dopaminergic neuron, and there is different result depending on the mutation used, and you can say no dopaminergic neuron abnormalities and Lewy body formation. So these are obviously some disadvantages as well with these model. Okay, so apart from this genetic model, there are some neurotoxin-based model of PD. These are most effective in reproducing dopamine deficit in the primate and rodents. So the most widely used compound for animal models of PD are We see MP, TP, rotenone, and 6-hydroxydopamine. This is 6-OATM. So in the next slide, you can see the mechanism of action of these neurotoxin-based making these neurotoxin-based model, how to use neurotoxin effect in this PD model. So yeah, I'll show later. But first, I discuss the advantages of these models are they like reproduce lesion formation and dopaminergic neuronal loss occur also in these model. Lewy bodies formation also occur. So these are the advantages, and disadvantages are like there is very like difficult to replicate due to the high mortality rate in these models. So it need the inject into the brain. So there are some disadvantages as well with this neurotoxic model of PD. Okay, so here, this is the mechanism of action of neurotoxin used in the model. So in the Parkinson disease, so 6-hydroxy this dopamine enter neurons via the dopamine transporter, this DAD transporter, and following several consecutive reaction, it is metabolized yielding hydrogen peroxide and paraquinone, and it thereby induce neuronal cell death via the production of reactive oxygen species. MPTP here in this MPTP rotenone as a lipophilic compound can cross the blood-brain barrier. So once inside the brain, MPTP is metabolized into the toxic cation, and this is MPP, by the enzyme monoamine oxidase B, MAOB. So in glial cells, so MPP enter dopaminergic cell via the DAT. Here you can see this transporter cell, which facilitate the MPP to enter the dopaminergic cell, and MPP and rotenone accumulate in the mitochondria, where they inhibit complex 1 of the mitochondrial respiratory chain, and rotenone can also induce depolymerization of cellular microtubules, which precipitate in the cell death process. So this paraquat enter the brain with the assistance of neutral amino acid transporter and catalyze the formation of reactive oxygen species via two mechanisms: redox cycling and activation of this reactive oxygen species generating enzyme, that is NADPH oxidase. Okay, so next is model for Alzheimer's disease. So AD is the main neurodegenerative disease and the most common cause of dementia. That is accounting for approximately 2/3 of dementia cases and affecting more than 35 million individuals worldwide. So AD affected mainly people over 60 years old, and its initial presentation is usually memory impairment, but later symptoms include visuospatial, language, and executive dysfunction. So as I told, describe in the start, that the histopathological hallmark of AD is the accumulation of neurofibrillary tangles and amyloid plaques, in addition to widespread synaptic loss, inflammation, oxidative damage, and neuronal death. So these tangles are formed by aggregates of phosphorylated tau protein. This extra cellular plaque are formed from beta amyloid peptides, which are fragments formed by cleavage of amyloid precursor protein. So animal model have significantly advanced the understanding of this AD pathogenesis. So to date, animal model used in preclinical study can be distinguished in transgenic model of AD, that is consisting in single or multi-transgenic animal overexpressing this APP and pre-senilin or TAW mutation. And the second is the non-transgenic models that obtained by toxin injection in the brain via the intracerebroventricular or intrahippocampal injection. So including direct injection of amyloid beta and TAW or TAW, the model of aging. For the model of aging. So the advantages of the use of non-transgenic models include the possibility of investigating the amyloid beta and TAW effects in animal different than mice, or for which transgenic model are not available. And number two is excluding the confounding effect of overexpression of this APP and its fragments, and also investigating the different role of this amyloid beta and TAW species. So you can say different concentration. So both transgenic and non-transgenic model do not produce the entire clinical feature of human AD, but we have a number of these to study. Okay, so these are the animal models for Huntington disease, and you know that HD is an autosomal dominant genetic disorder that is characterized by progressive motor dysfunction, cognitive decline, and behavioral symptoms. So there is Huntington gene which encode an expanded polyglutamine stretch near the Huntington protein, basically the N-terminus of the Huntington protein. So mutant, this Huntington protein is widely expressed and believed to induce neurodegeneration through an abnormal interaction with other proteins. So this lead to cellular alteration, including abnormal vesicle recycling, loss of signaling by brain-derived, like BDNF, brain-derived neurotrophic factors, exocytosis, or you can say decrease intracellular ATP level, and mitochondrial and metabolic disturbance. So ultimately, so as we know that genetic diseases, this HD is a genetic disease and it caused by the single gene mutation. So the most commonly used animal for modeling HD are transgenic mice and knock-in mice. So mouse is the most commonly used mammalian genetic model due to its efficiency and economy and ease of manipulation. So these animal models have been important tool to investigate the pathogenesis of the disease and to try to develop therapeutic strategies. So this model is widely used for drug testing due to its rapid onset. So some example here in these model, these are some examples of the transgenic mouse model of for Huntington disease, and that express full length this Huntington HTT containing these 128 and 97 in this model, this one. So knock-in model should be, like you can say, optimal to reproduce the human pathology because they are most faithful reproduction of the genetic mutation and do not overexpress this HTT or disrupt endogenous genes by this integration into the genome. So these are mutant, some knock-in and transgenic model for this Huntington disease. Okay, so next is animal model for ALS, amyotrophic lateral sclerosis. So ALS is a you can say fatal late onset of neurodegenerative disorder that is characterized by a progressive loss of motor neuron of the CNS leading to muscle weakness, wasting, and spasticity. However, it's the bitter truth that patients with the ALS usually die within 3 to 5 years after the diagnosis, and also this ALS are usually inherited in an autosomal dominant way. Although there are some autosomal recessive and X-linked form. So mutation is more than 10 different genes have been identified to date. So the most common mutation are found in the gene encoding superoxide dismutase. This is fused in sarcoma and TDP 43, DNA binding protein 43. So different mechanism that is already been suggested to play a role in the pathogenesis of ALS. These include astrocytosis, neuroinflammation, mitochondrial dysfunction, deregulated autophagy, and axonal transport dysfunction and retraction. So there are different these mouse model for ALS, such as this two transgenic and knockout model. So advantages of these models include like these knockout models, significant distal motor axonopathy shows in these models, and in transgenic mice, many feature of ALS. It shows axonal mitochondrial dysfunction shows, and progressive neuromuscular dysfunction shows in this these model. Gliosis and motor neuronal loss also you can see in this model. But obviously there are some disadvantages because in some knockout models, these does not present like motor dysfunction and maybe, but not at least up to the 6 month of age. It's not there is no motor dysfunction present up to this 6 month of age. And transgenic and these transgenic models have variable ages of disease onset. So these are like some disadvantages of for making these models. Okay, so there is another neurodegenerative diseases, and these are the models for this. This is FTD, frontotemporal dementia. This is the third most common form of dementia across all ages after AD and muscular dementia, and it is leading cause of early onset of dementia. So FTD is characterized by progressive deficits in executive function, behavior, and language. So FTD is classified into 3 clinical variants: behavioral variant FTD, which is associated with behavioral and executive deficit. And in FTD, initially, focal degeneration affecting larger region in the frontal and temporal lobes, and patient develop cognitive impairment and motor deficit. and may include Parkinsonism and motor neuron diseases also in some patients. So basically before 2004, tau was the only molecule known to accumulate in the brain of a patient with FTD. And mutation in the microtubule associated protein tau gene were the only known genetic cause of FTD. After 2004, two new neuropathological substrate, that is TDP43 and and 6 new FTD genes, that is like GRN, first CHM2B. These are not mentioning in this models. So these genes have been identified. So these advances have created new opportunity to study the FTD using rodent model and to use this important tool for studying pathophysiology of neurodegenerative disorder and new targets for treatment. So, and advanced transgenic mouse have many advantages, and astrocytosis developed. This is basically before you can say 5 months of age, and learning, memory, and motor deficit also you can develop in this model around the 7 months of age. So these like advances occur in these area for making this model for FTD. Okay, so in vitro models are alternative to animal model. Okay, so up to now we see the model for in vitro studies. So in vitro research is a study of animal and human tissue outside the living organism system. So organ, tissue, cells, and their component are isolated from the organism, generally post-mortem and cultured using appropriate, like supporting this media, aqueous media. So in vitro model have been widely used to simplify the study of complex phenomena of the in vivo environment, that is creating well-controlled and easily accessible condition for the quantitative and repeatable evolution of cell response. So, and also this is the quick and require modest amount of material. So it's also like beneficial. So in vitro experiments are necessarily a simplification of the more complex living organism and are usually designed to answer specific question. And obviously a good scientist should be aware of the limitation and boundary condition of such test. So being careful not to over-interpret experimental results. So in fact, how you can say accurately the experiments recapitulate in vivo condition depends on the study design as well as the desired you can say outcomes. So you can see in this figure that like the in vitro model have a wide range of application in many different fields, from toxicology and drug testing to tissue engineering and nutraceutics. These are. Okay, so cell culture is a promising approach to complement animal data or completely substitute it. So cell originating from animal or human biopsies are grown in the artificial environment and are subjected to control condition, including parameters such as pH, osmolarity, temperature, humidity, and gaseous atmosphere. So culture medium is used to provide cells with nutrients, that is amino acid, vitamins, inorganic salts, and carbohydrates. So these are the in culture medium which provide these nutrients. So cell culture represent an indispensable tool to improve our understanding of cell biology and in vivo cell behavior mechanism. So it is making rapid progress, and its development has the potential to lead to a decrease in animal use. So you can see here in this picture, so there are different cell culture technique, including 2D and 3D method have been developed. So neuroinflammation is can say believed to play a primary role in the pathogenesis of most neurodegenerative diseases, include like Alzheimer and Parkinson. So in these this neuroinflammation play a major role. So currently suitable in vitro neuroinflammation models for studying cellular interaction and inflammatory mechanism at the neurovascular unit are like still scarce. So in this diagram, experimentally flexible, this tri-culture neuroinflammation model established, combining murine microglial cells. This is like you can see here NL11, these microglial cell, mouse neuroblastoma, neuro 2A cell line, and brain microvascular endothelial MVCD3 cells in a transwell co-culture system that is stimulated with lipopolysaccharides. So neuroinflammation induced in this triculture model as manifested by activated NV11 cells via toll-like receptor 4. This is the mechanism of it. So resulting in increased release of pro-inflammatory mediator, that is nitric oxide, interleukin 6, and TNF factors. So through the activation of nuclear, this factor KB signaling pathway. So through this signaling pathway, these neuroinflammatory mediators are released. So this triculture inflammation model mimic the microenvironment, the cellular crosstalk, and the molecular events that take place during neuroinflammation. So it provides a robust in vitro model for studying neuroinflammation mechanism and screening for potential therapeutics to treat various neurodegenerative diseases. So here my presentation, these are the references. So here I must say thank you for your presence and patience with me. So now I will stop here and will request Dr. Roxana Nawaz to join you. How we conduct in vitro study in the lab. Dr. Roxana will explain you more in detail about the these in vitro models. So thank you so much. Dr. Roxana, now over to you.
Thank you. We welcome Dr. Roxana on board.
Hello, everyone. Can you hear me?
Yes, ma'am, we can hear you.
Okay, so I already downloaded the video in vitro video for you. Then I will request the organizer, they can play that one. And after that session, I'm here and I will give you the activity and will explain you. And then after that, you will do the activity and we will have another video. The organizer will play that video. And then after the second video, you will have a second activity. So I'm here to help you and conduct this activity for you. Okay, so please organize it. Thank you, Dr. Saima Gul, for such a nice presentation, such a nice and informative presentation. I hope our students will get the benefits from this presentation and the workshop. Hello, everyone. First, I hope and wish you that you all are safe and healthy. My name is Roxana Nawaz. I'm a researcher in Behavior Neuroscience Lab in the United Arab Emirates University. Before we start our lab session, I would like to say thanks to all the organizer, IBRO Pakistan organizer, They have conducted very wonderful workshop and a conference. And of course, they give us the opportunity to share our experience with you people. So today, actually, today basically we have planned this lab sessions, which is actually based on the in vitro research model. So Dr. Sarmagul already talk a lot about this in vitro and in vivo model. Because of the shortage of time, we cannot go through the in vivo model. We just want to share with you in vitro model, how we work on in vitro model and what are the needed things you need to do to have in the lab, so you can start your in vitro model in the lab. So this is actually behavior neuroscience lab. So mostly we are targeting here the neurodegenerative project. So for the in vitro model, if we are talking about the in vitro model, it means we are talking about something outside the body. It means inside the cells, but outside the body. So if you wanted to make a neurodegenerative model, you need two important things before starting this project. One is a neurotoxin agent. Second one is a neuroprotective agent. So in neurotoxin agent, you need to cause the damage in neuronal cells. Neuroprotective region, you need to see how these agents affect the neuronal damage. It's in a positive way or a negative way, or there is no any significant results. So for this study, for this, before I give you the explanation about the in vitro model, let me give you the brief detail about this in vitro in this cell culture. And here, this is our cell culture lab. For any cell culture lab, you need a water bath, you need a CO2 incubator, you need a -80 fridge, a normal fridge. Of course, you need a centrifuge, microscopes, and very important thing is biosafety cabinet. Okay, so today we are targeting SHSY5Y cells. These are the neuroblastoma cells. So our master student, Miss Wala, she is working on these neurodegenerative models. So we will start from this first step, from thawing the cells. Thawing the cells, you can thaw the cells from either from a new vials you are getting from any company like the ATCC or other company they are providing you, or you can also thaw the cells from your preserved cells. Okay, so today we are going to start this thawing the cells. We already preserve our SHSY cells to show you how these cells work and how we are doing this, adding the agents, neuroprotective and neurotoxic agent. Before starting, I just want to give you some highlights about the today workshop. In today workshop, we will do first, we will give you the little explanation about the neurotoxin, which neurotoxin we are using in this research project, and plus neuroprotective agent. Of course, I'm not going to reveal the name of the neuroprotective agent. This is our lab privacy, but of course we will mention it a drug name, so drug 1, drug 2. Okay. And today we will show you the cell count. In our lab, we are using two methods to count the cells. One is a manual method and second is the automatic cells count method. So before we come to the cell count method, first we will wanted to show you how to thaw the cells. For thawing the cells, you need a complete media, because in vitro model or in cell culture, you have to decide which cell lines you need it and what kind of work you want it to do. After deciding the cell lines, you have to take the media according to the cell lines. It depends which cell lines you are using. Most of the time, the DMEM media you can use for more than one cell lines, but some kind of neuronal cell lines, like if you are working on the neuronal cell lines, you need a special media with a high nutritions. So that's why we are using the DMEM F1 12 media. This is specifically for this SHSY5 cell lines. Okay. So let's start with the thawing the cells. Our master students Wala will show you how to thaw the cells, and then we will do the counting, and after counting we will show you the calculation. Okay. So now before start our initial step of thawing the cells, I just want to tell you about some brief detail about the neurotoxin. Neurotoxins play important role in a neuronal death. So you have to decide which model you wanted to work. You wanted to do Alzheimer model, dementia model, Parkinson model. Based on this model, you need to select a neurotoxin. Like we here in the lab, we are mostly working on the Alzheimer and dementia model, and sometimes we are just making the brain damage model. So we are using this L-glutamic monosodium. What is this L-glutamate? You all know about the glutamate. Glutamate is an excitatory neurotransmitter. When this neurotransmitter is present in a lower concentration, in a less amount, it plays a very important role in a brain matter. But the concentration of this glutamate is become increased, then it's become toxic for the neuronal cells. What happened? It induced the calcium influx, and which lead to the swelling and necrosis. So this glutamate is also a neurotoxin. It has a neurotransmitter role plus neurotoxin. So in the lab, we are using this with the higher concentrations to cause the cells, neuronal cells necrosis. After the necrosis, we are treating these cells with our drugs. These are our neuroprotective reagents. Of course, I'm not going to give you the name of these reagents, but I just want to mention it like a drug 1 and drug 2. Okay, so these are our drug 1, drug 2 neuroprotective agents, and we are using the glutamate as a neurotoxin agent. So let's start our sessions. Our student Wala, she will explain you about the going of the cells. So you can come close and see. So first, she is going to give you the explanation about the complete media. We are working on SHSY cell lines, which is a neuroblastoma, human neuroblastoma cell lines. For that one, we are using this DMEM-F12 media, which has a high mutations media. For making a complete media, she already actually prepared the complete media. This complete media, she already prepared it. For preparing the complete media, you need 1% penicillin, streptomycin antibiotics, okay, and you need 10% FBS, okay, and the remaining you will add the incomplete media to make it complete, okay. So now we will start with the thawing the cells. She will take our preserved vial SHSY cells. We will take this SHSY cell lines and we will keep in our incubator water bath for 1 minute. To let them melt the cells, and then it's downward. So we have kept our cells. We will put our vials in our incubator for 1 minute. So when you are working in the cell culture, you have to keep in your mind that the safety of the cells and safety of yourself is very important. So you always keep prepared before starting your lab or before starting any experiment. You need to wear gloves, lab coat. If you are not wearing a scarf, you have to cover your hairs with the cap, and you have to use the ethanol, 70% ethanol all the time in the lab. Okay, so now Vala, she wants to thaw the cells. For the thawing the cells, you need to add some close. She already clean and sanitize this whole area. So now she will take 4 ml of the media, a complete media, into a 15 ml tube. Now she will take the vials from the incubator. Now she will take these 1 ml, because this vials contain 1 ml cells. So she will take this 1 ml and put it in a 4 ml containing tube. Yeah, you have to be very careful about when you are dealing with the cells. You will not open and use anything which is not sterile. So whatever things you are seeing inside the hood, this biosafety cabinet, these all are the sterile, and we used to spray ethanol and we used to turn on the UV light frequently. Yes. Now she will take these cells from the cell vials and she will add in the tube which has a 4 ml fresh media, fresh complete media. Yes, we have to keep this one in a balanced forms. So whatever we are keeping here, this one you should have another tube opposite, otherwise this machine will not work. And now we will centrifuge, we will leave it like that because it has, the temperature has to become for the 4. So we fix the 4-degree temperature, 400 RPM and 5-minute time duration. So till that time it will done. I wanted to give you some little explanation about this cell count. So after these centrifugations, we will take the out the supernatant and we will add the fresh 1 ml media, and then we take these cells to count in automatic cell count machine, or we also use this one. So for counting the cells, we are using 2 kinds of method in our lab. Sorry. So one is this is called the automatic. For automatic, we are using a hemocytometer. This hemocytometer. Okay, for the hemocytometer, if you are working with the hemocytometer, you need a triptan below solution. Okay, and you need, of course, your cell suspension. These 20 microliter, this triptan below dye, and 20 microliter cell suspension. When you mix them and you will add here on the center of this hemocytometer, and then you will cover with the cover slip, and then you will observe them under microscope. How it looks like, I wanted to show you. So this is when you add the media and add the tryptophan group, then you will observe under microscope, you will see like this one. This hemocytometer is give you this kind of pictures. So you will have, if you see, you can see the 9 square in this picture, but you will just focus on the 4 square. The count 1, count 2, sorry, I'm giving you the count 1, count 2, count 3 and count 4. Only we will count the cells which are present in these 60 big square which contain a 16 small square. Okay, for this one you have to count the cells. Okay, you will not count the cells which are present at the edge of the lines. Okay, you have to only count which are present inside this big square. Okay, so if you see this, it's showing you the white circle and the purple one. The purple one is what and the white one are what, because this hemocytometer is giving you the count of the cells which are dead or the count of the cells which are alive. So you are counting the viable cells and the dead cells. For the viable cells, you will see the white. White one means the dye cannot penetrate. So the live cell will not let the dye to penetrate inside the cell. So they are the live cells. The dead cells which penetrate, the dye will enter and it's become a purple in color. Okay, so in this way you have to do the counting. I will show you the counting of hemocyte after getting all the data, all the cells from a hemocytometer, how to count the total number of cells and viability of the cells. I will show you it later. First, I just want to give this explanation. For the hemocytometer, you need this one. But if you are working on, but of course this hemocytometer is taking time. So come here. This hemocytometer takes little bit more time as compared to show this one. This is we are using, of course you will find a different company cell count, automatic cells count machines. So we are using from the Moxie. So here you will see you just need this machine and of course the cassettes. You don't need to do anything, you just need these cassettes which each cassette counts two times. Okay, so we have to count like each cassette has a 2 applications. So you just need this and this one. Only you need a 75 micrometer cell suspension. You just put it here, put this cassette inside this Moxie automatic cell counter, and then it will give you direct total number of viable cells per ml. You will just take and according to that cells you will divide and do the calculation how much you need per how much you need for your what you call it running the experiment each one, because if you are going to see the neuroprotective agent effect, you need to work on either a petri dish or 6-well plate, 12-well plate or 96-well plate. According to that, what you want to do, either you are using the 96-well plate, of course you will not go for more than 20,000 or 25,000. Okay, if you are working on a big plate, of course the count should be different. So based on this you will do the counting and then you will reach to the final volume, how much you will take from the cell suspension to run your experiment. Okay, so now we will go for the cells one. 7:30 now start. Okay. It will start now. So now it will take little time. Certification is done. So we will take out our tube. So here, after the centrifugation, we can see the palette. This palette is down. I don't know if you can be able to see the palette of the cell suspension is down. Now we will discard the supernatant and we will add the fresh media. We will take 75 centimeter flask. These are the discarder we are keeping inside with the antibacterial, bacterial detergent we added in this one, so there will be no contaminations. Before doing this one, we have to label. We are using SHS5. You have to write the name of the cell lines, then you have to write the passage number. Passage number was 7 and of course today date. Now I will discard the supernatant. The palette, I have to see the palette location. My palette is here, so I will try to remove the supernatant or add the pipette opposite side. So in this way, the pipette will not disturb the palette. So now I have removed. I will discard in a discarder. I will add the fresh media. I will take 1 ml fresh media. So I will mix this smoothly and gently. You can also do the slightly vortex. You can also use the vortex to mix the palette with the media. Now I mix this one. Now I will take a 9 ml fresh media in a 75 flask and
I'm trying to avoid the bubbles, but of course when you mix with the pipettes, it will cause the bubbles in the samples. So now we have to see our flask under the microscope to see the cells. We have it. Then we will I will try to show you, because we already connected our microscope to the computer, so we can also see cells direct in the cells image direct on the PC. So this is the software. Let me first focus the cells. Because now we freshly add the media and cells are floating in the media. It will take 24 hours to let them to attach on the surface of the flask. So after the 24 hours, when you see them, they already attach on the surface. After the attachment, they start division. Okay, so when the neuronal cells are not in a dividing stage, you will find them in a circular shape. When they start division, they are ready to start the division, then they start themselves in a longitudinal. So right now they are freshly added, that's why. So we will change the lens from lower magnifying to higher. Okay, so now we will see the the cells are floating, so we cannot fix them at the one. Now I'll show you. Look. So now our neuronal cells are in a resting stage, means they are in a circular form. So once they attach with the surface, they are ready to start the divisions. Okay. This one is down. We will do the counting of the cells. We will keep our cells in the incubator. Incubator which has a 37-degree temperature and 5% CO2. Now we will do the counting of the cells. For the counting of the cells, we need a 75 microliter cell suspension. We already have this one. We will use that one. Okay. So I will use the pipette. Okay. This one is already fixed on 75 microliter. So we will use that one. Now So last time we already used this side. As I told you, the one cassette has two applications. You can use one cassette 2 times. So this red means we already used that area. So we are going to use the other side. Okay, so now I will bring the sample. We have to turn on it. Just press this one. Okay, now we will add sample here. Adding 75 microliter of the cell suspension. Okay, now we'll read. So we will note down the total number of the cells we receive in this software. We will get this in software. So we get 1.13 multiplied 10 to the power 5 cells per ml. These are our cells. And these are the calculation in the graph. You can see it. Okay. So now you have seen we did calculate. We did a cell count in automatic and manually. Manually, actually, we did not do because we don't have enough time to run this experiment because it takes more than half an hour. So that's why we just taking these pictures which are showing some viable and the dead cells. So by using this data, we will calculate the total number of cells per ml. Okay, but the manually, the automatic cell count give us a total number of cells 1.13 multiplied 10 to the power 5 cells per ml. So in automatic system, you don't need to do any calculation. You just receive that this amount. If you go for this one, it means you have so you have 113,000 cells per ml. This was counted by automatic cell counter. Okay, so now this one. So this one you have 113,000 cells per ml. So of course you need to know how much. Cells are in 1 microliter. So you will do this calculation for me. Okay, we will give you the worksheet after this calculation presentation. Then you will do the worksheet, questions for me, and of course there are some other questions as well. Okay, now we will do this manual calculation like if you are having a data from a homocytometer. So how you will calculate after getting the data? Suppose you will receive this one. So as I told you, the total count, you have a formula, total cells per ml. You have total cells. If you are going to count the total cells per ml, for that one you need a total cells counted multiply by a dilution factor, multiply by 10,000 cells per ml. Okay, so before we go for this formula, we need to know this one, viable cells count. Viable cells count means count 1, means you have to see how many viable cells are present in count 1, count 2, count 3, count 4, means in a 4 square. Okay, then you will divide them all, you will add them and then divide it all of them with the 4, because 4 means 4 square. Same you will do for the dead cells.
Okay, so for example, we are using this data. So see here, how many cells, we will not count these cells which are present at the edge of the boundary line. Okay, so we have 1, 2. So count 1, I'm counting viable cells. Viable cells in count 1, how many I have? 2. Plus in count 2, how many I have? 1, 2, 3, 4, 5. 5. Okay, in count 3, how many viable cells I have? 1, 2, 3, 4. I will not count this one. Okay, so how many? 4. Then count 5, count number 4, 1, 2. Okay, so we will do the calculation. Okay, now you will do the same things for the dead cells. 1 in count 1, 0 in count 2, 1 in count 3, and 1 in count 4. So 3 divided by 4. Okay, so now we will see, we will take off this one because we already counted from here. Now we have a formula. Okay, so 4 divided by 13. There is a hope it's working. I will take 1 minute. So now you have total number of dead cells per ml is 0.75 and total number of dead cells in viable cells in per ml 3.25. Okay, now you have this one. Now we will go for the total viable count. Okay, so for viable count you will use the viable. Okay, so here this formula. So sorry, not this one. Sorry, this one we already done it. This one. So now we will see the viable cell. Total cell count. Now total cell count, you are counting the viable cell or a dead cells. You have to put the value of dead cells here. So I'm counting the viable cells. So how much the viable cells I get it? 3.25. Then multiply by dilution factor. We have a 5 dilution factor. Multiply by 110,000. These are the cells per ml. So we will see. These are the viable live cells you have in 1 ml cell suspension. The same calculation you will do for the dead cells. Okay, if suppose we are doing for the dead cell, the same formula you will use. These are the total number of viable cells present in cell suspension. Now you are doing the dead cell, so we will do same here. So we have a total 0.75. We will multiply 0.75 with a dilution factor 5, and then we will multiply by 10,000.
25,000 cells per ml. Now, when you count the total viable cells per ml and total dead cells per ml, then you can able to count the viability. Okay, so viability formula is, what is the viability formula? Total viable cells per ml, total. Okay, and total dead cells plus viable cell. You will add dead cells calculation with a viable cell calculation, and then of course you are making the viability in percentage, you have to multiply by 10. So we have a total viable cells, how much? We have a total viable cells 1, and if we count them, both of them, you have a viability 68.4%. This is just, we take this, of course, this by using this picture data. Of course, when you will count this, the data reading is different than this one. So you might have 97%, 98% viability, okay? I just did this calculation based on the available pictures, okay? So this is the formula you will use for total cell count and the viability, okay? Of course, I will give you this worksheet and you will see the formula there and you will do the calculation and send to us, okay?
That was a really nice elaborative session. Dr. Rukhsana and Dr. Saima Gul, we have some questions in the chat box and on the YouTube. So I will narrate those questions, and meanwhile, Ujala will prepare the activity for you. So you can answer the question. First, we have a question from Osama Aman. He wants to ask that, is there any relationship between substance P and Alzheimer's disease?
Yes, there is. Hello, am I audible?
Yes, you are audible, ma'am.
Okay. Yes, there is a relationship between substance P and Alzheimer disease. Basically, in Alzheimer patient, there is like decreased substance P level in some brain regions. Like hippocampus and cortex. So substance P used as a neuroprotective agent, like we can use it. So what it do, it will basically produce the neuroprotective effect through the inhibition of beta amyloid induced overexpression, and also it can increase the gamma secretase level. So by these we can like use as this substance P as a neuroprotective.
Okay.
Okay.
So,
yes, your screen is visible, ma'am.
Okay, so we will take the question answer session at the end. Let's first do this activity. Okay, and before I will explain this activity, I wanted to tell you that if you are working in cell culture and you are targeting in vitro model, no matter you are targeting in vitro neurodegenerative model, you are targeting in vitro cancer model, any other model, you should know first an important step, which is actually a basic step, but very important, which is a cell count and viability. Before doing any step, you cannot be able to target anything if you don't know how to calculate the accurate amount of the cells in your media, or how much you need it, and how you know that the cells you have are viable or dead. So that's why I explain and this step in in a really detailed way. So now I already explain and give you the formula. You will see the formula at the end of this page. So this formula will help you to calculate. Now you can see this on your screen. There is this is actually a data from hemocytometer. As I told you before, you will not count any other chamber except the 4 square, the one which are more visible, okay? So you will see the 4 square, which is, you will give them the name, like count 1, count 2, count 3, and count 4. So now you have to count the total viable cell per ml, okay? And you will count the total dead cells per ml. And then when you count viable cells and total dead cells, you will go for the cell viability. You will see the formula, okay? So now here I already explained, you will see the dark circle, which is our dead cell, and the light one is our live cell. So now I don't know I will ask the organizer how much time we can give them to do this calculation for us. Is it 10 minutes or 15 minutes? They can start now. If you have any questions during doing this one, ask me in the chat box. I'm here to answer you, okay? Yes, Farah, how much time we can give them? Is we have to mention the time so they can finish on time.
5 minutes.
5 minutes, not it's very less.
Then give them 10 minutes.
10 to 15 minutes we can give them.
Okay, done. Okay. They'll have 15 minutes then.
Okay.
I request all the participants to calculate, to perform this whole activity and calculate the numbers, and leave your answers in the chat box so that Dr. Sana and Dr. Saimagul can see and evaluate your results. Thank you.
Can you little zoom, because they cannot be able to see the formula. The formula is down. See if they can see the full image. Okay, thank you, my dear. Kindly, can you please move the cursor little down? The students cannot see the viability formula. Thank you, Farah.
Dr. Roxana,
I think it's enough.
can we proceed now?
Yeah. Whoever who did not be able to finish can submit it later. Then I will give you the complete answer because I have seen there are some students they are also doing on YouTube. Miss Farah, I have a questions. There are some students they are watching the live sessions on YouTube, but they are asking the questions there. I'm not be able to see their questions here on the live chat on Zoom. So can you please solve this issue?
I will narrate the questions, ma'am, for you.
Okay, khalas. Okay, students, so till now you can stop here. Whoever submit the answer, I will see them and then I will give you the correct answer at the end of the session. Then please submit your answer here, okay? And now you will see another video. Actually, because just to tell you, we don't have a much time, so I cannot be able to show you all the learning experiment in our cell culture. So we already run one experiment, which is called the MTT assay. I already explained in the video, you will see, and then I showed you the calculation. Why I explained this MTT assay? Because this is the first assay in the cell culture to target any drugs to show to see their effect on the memory cells, on epithelial cells, on the neuronal cells. So you have to first do this assay to see if your drug is affecting or not. So that's why I explain you this assay and plus its calculation. Yes, Farah, you can play now.
Ma'am, before the video, can we complete the question answer session, please?
Oh, sure. Why not? I don't mind.
Okay. We have a question from Anna Askari. She wants to ask that, is there any way to investigate potential predictive ability of DNA methylation?
Yes, there are many. First thing, DNA methylation is an epigenetic mechanism which modify the gene expression. So right now in advanced technology, there are many methods you can use to detect methylations in a human blood genes assays. You can also do in a tissue cells. You can also do in cell lines. So what are these assays you can target? There are sequencing, advanced sequencing, and you can also go for the microarray analysis, and of course single cell assess method. You can also target this one. It's up to you, availability, where you are working and what kind of equipment or instruments you have in the lab. Based on this one, you can do that one. But right now, the advancement in size, a lot of assays you can find out. And you can target whatever the genes, methylation, demethylation you want to see, any specific cells, tissues, you can do that one. They are available. So there is no any, you say the impossibility. Okay, is there any other questions?
Yes, there are. Another question from Anna, that what are the biomarkers of other types of Parkinson diseases, such as drug-induced Parkinsonism?
Yes, Ms. Samagul, do you want to answer this one?
No, you will answer. Maybe this is if you can answer according to the in vitro study. So
okay,
because I already mentioned in vitro model there are some drug induced.
Okay, when you are targeting Parkinson disease model in vivo or in vitro, first you have to see which channel, because these are the we are talking about the neuronal cells. So neuronal cells, because there are one person I have seen on this YouTube channel, they were asking the blood brain barrier things. I will also explain that one. So mostly there in our lab, we are actually when we are doing this induction things, so we are always focus on the calcium channel blocking. Okay, so but there are a lot of biomarkers. You can categorize them based on what actually you wanted to see. As Dr. Saima Gul already explained in her presentation regarding this Parkinson mechanism, Parkinson disease mechanism and pathology. So there are many things you can do. You know that the main important neurotransmitter in Parkinson disease is dopamine, which affect human motor activity. You got it? So dopamine, after you know that this is the most important neurotransmitter in Parkinson disease. Based on that one, you can also see the biomarkers expression channel. You can target the genes. You can do any other things or if you want to do the protein, you can also go for the protein channel, dopamine protein channels and other things. But if you ask me, that which important biomarkers we are targeting. Actually, most of our work we are here doing on the gene expression. Okay, so first we first we investigate their effect. After we once know that these drugs is affecting against the Parkinson disease, then we go for the further DNA expression or DNA methylation. Mostly we are here in our lab, we are doing the DNA fragmentation to see the methylation effect on the gene. So this is an important procedure we do in our lab. Actually, I forget what was these questions. He asked the models, or what he asked the markers only, or what?
Just the markers, ma'am.
Yeah, markers you can, there is no specific, now there is too much advancement in the science. So what actually you are looking for? You are looking for the protein side, you are looking for the gene expression side, or you are looking for, because this is clinical variant, genetic variant, protein variant. So see, according to that, you can target any biomarkers. But mostly here
it seems we have a lot of questions. I'm really sorry to interrupt you, but
okay,
students are kept coming with many questions, and all the participants are showing so much enthusiasm.
First, I love to. By the way, you can give them my email address. They can write me. I will explain each and every one, and happy to explain. Okay, so if
just the last question, first from Shuja Heather, that he wants to ask how neuroprotective interact with blood-brain barrier in vivo.
Okay, this is very important questions. When we study this, some kind of neuroprotective agent in the lab. So first, our main question is that these agents have a capability to cross the blood-brain barrier or not. First thing, we are looking for the agent is soluble in what? Based on that one, we are targeting. Now you can see blood-brain barrier is actually what you have seen. This is a semi-permeable border, right? Which this border has an ion channel. This border have the permeability, and some agents, they are actually diffused through the the blood vessels. So reach to the neuronal region. So this is actually a long target question, but right, Farah told that we don't have much time. So I will explain and give you a lot of reference regarding this one. You can go through that one. So right now we have to play the second video, and then I'm happy to answer you. You can, Farah will share my email with all the participants. So you can write me. I will give you the all explanation about your questions. Okay. Yes, Farah, please.
Sure, ma'am. Thank you.
Okay.
Any more questions, Farah? No, ma'am. There's no more questions. She wants to play the video, and she wants all the questions to be emailed to her.
No, Farah, I think there is a question. I think I heard one of my colleagues, there is in YouTube channel, one question about the...
And there are so many questions, but
okay,
Dr. Sana said she will answer it on email. Yeah.
Okay. So it's okay. Okay. So you can play the video now.
Now, after the cell counting, we run the MTT-assay. Because of shortage of time, we cannot be able to give you the all detail about the MTT-assay, how we seed the cells, and then what reagent we added, because it takes long time, and plus we need a 24 hours incubation time, and then plus after the 24 hours in after seeding the cells, we need to keep the cells for 24 hours, and after 24 hours we have to run the MTT assay. For MTT assay, I just give you the graphical presentations what we have actually done. We already prepared the plate, but before I run this plate in the ELISA reader, so I just want to give you the brief detail what we actually have done. So for the MTT assay, we designed our experiment. We seeded our cells. We need just now I give you the detail of the cell counting. After the counting, we know that we need 311 cells were in 1 microliter. So we need a 15 to 25,000. This is the requirement for the 96 well plate. If you are running experiment on 96 well plate, so you will not exceed the cells count limit more than 25,000. So we targeted you can take a range between 15 to 20,000. For us, in our experiment we took a 20,000 cells per well. Okay. And then we treated them after CD96 well plate. We kept this 96 well plate in an incubator for 24 hours. After the 24 hours, we ate or treated our cells with a drug, which is we give the name drug 1. Okay. After treating our cells with the drug, we again kept our 96 well plate in our incubator for 24 hours. After the 24 hours, after 24 hours time period, we add the MTT reagent. After adding MTT reagent, we incubate for 3 hours. Okay, again we kept for 3 hours. After the 3 hours of incubation, we add MTT solvent. After adding MTT solvent, we again kept for 15 to 20 minutes incubation. After this incubation, we will take the reading. Okay, these are actually all the graphical presentation that we have. Because this 2 hours workshop, we cannot give you all an on-hand experience, and we cannot make a video or give you the virtual presentations of all the experiment we run. So that's why we already prepared the plate. I already told you what we actually have done. So before I run this plate in an ELISA reader, I just want to give you the little explanation about MTT. Maybe you all know about this one. MTT, what is actually MTT? MTT is a name of a dye. A dye name is a tetrazolium. What this tetrazolium is doing and why we are using the MTT? What are the requirements to do this assess? And tetrazolium dye, actually this tetrazolium dye is the name of this assay. That's what the name is little big, that's why they are using the short form MTT. So MTT is actually a tetrazolium. This tetrazolium dye is actually using the same function which we are doing with the manual method of counting, like we are using the tryptine blue solution. But for that we are counting the cells of viable and dead. Here we are doing the same procedure, but the difference is that in this we are counting the cells after the drug treatment. Okay, so here when you use the MTT assay, you are treating your treated cells which already treated with the drugs. After their treatment, you are using this dye to see the cells functions, to see the viability of the cells, to see the organelle function in the cells. So this assay is actually revealing about the viability or a function of the cells after the drug effect. So that's why we first in cell culture or in vitro study, first we wanted to see if you wanted to know any drug effect is affecting your cells or not. So you have to target first MTT assay. So now we already have prepared our plate. I will just go and show you this plate after adding the MTT reagent, MTT solvent and all the incubations. Our plate is ready to read in a ELISA reader. These all are already the experiment, we already run it. So before doing this experiment, we always I show you here. Look, this is your plate. So how you run your drug experiment or how you treat the cells in a plate. I just give you the little. So this is the plate. If you see, this plate has an alphabetical A, B, C, D, E, F, G, H, and then it has a number 12. So it means they have A to H rows and 12 column. So each and every sample or each and every concentration you have to repeat 3 times. So our first A is our control. Okay, it means without treatment, no treatment. And from B onward, we use the concentration difference. Suppose if
my A is control, so my B is my concentration maybe 1 micromole, then C is concentration of 5, drug concentration 5 micromole, then onward we use the different concentration. Here we use the triplicate because in any SS you run in that in vitro study, you have to give the surety about the accuracy, the results are accurate or not. That's why you need to do in a triplicate. Okay, so this is the MTT assay, and we are using these different concentrations. Once after adding the dye and the solvent, the color of the cells will change. It means you can see we have already done some more experiment. They are saying this is a purple, but it's not a purple color all the time. Sometimes you will get a brownish color, sometimes you will get a blue color, sometimes you will get a little mild like a black color. So it depends. So like this one we already done it, we have to just do the reading. Okay, we are using the Synergy HTX ELISA reader from the biotech. So this is like advanced system. By using this experiment, you can do the absorbance and fluorescence. If we have some masses on the fluorescence, you can also go for the fluorescence. Now, if you go and see the software, how we are doing this one. So we will first open, let me explain you here. So this is our software, we will open it. Okay, now we are going for the new one. So first we will go the actions of read. They will ask you either you want the absorbance reading, fluorescence or luminescence, but we don't need the fluorescence and luminescence, so we need absorbance. So we will click on the absorbance. Okay, so they are asking our absorbance reading is 570. Okay, so we will here put the reading. So khalas, only this one, you don't need to do anything one. So now it will come. Okay, now we open this software. We will first give the layout to our plate. So we, of course, we have a blank S6 control positive and our samples. Okay, we'll give the color black and this one. Okay, okay, sample. Okay, now they are asking the blank. We have this one, CTL we have this one, and sample we have this one. Okay, so these are the labeling. We have blank and control and then all our sample spreading. Okay, when you're done, okay, and then this is the plate we prepared. Okay, look, can you see the change in color? So now this change in color is actually showing the effect of dye on the cells. So we will now see. Okay. Now I'm reading the plate. Okay. Okay, sorry, I forget to take off this. Now you will see. So now we are getting the readings. So it will take little time. Till that time I wanted to explain you here. So these are the formulas. Once we receive all the readings, then you have to do the calculations of the viability in percentage. So how we do or count the viability? So in this way you have a control and reading. This D1 is actually showing the drug one. So I have a first sample is drug 1 with 1 micromole, second drug 1 with 5 micromole. drug 1 with 10 micromole, drug 1 with 15 and 20. So I have a concentration started from 1 micromole till 20 micromole. These are the readings. I already took it, so this one. So now they will give you all the readings here. Okay, they will ask you to save, then you have to save it with today dates, MTTSA. Okay, now this, after getting the reading, you can also get the statistical analysis here as well. This all, and here you can go and they will show you all the statistical analysis from this one. Okay, because this one is already done, so we will show you here direct. The readings from our ELISA reader, I already actually make this reading for you, and I just want to explain you the calculation how to do the cell viability count in MTTSA when you are running the MTTSA. So you have seen on the software that we got these readings. So when we get this reading, so what we have to do after that? You have OD values. After getting the OD values, you have to calculate the viability of each reading. And then when you calculate the viability of each reading, then you will take the mean of these all cell viability count. Okay, then this is actually the mean you need to draw the graph. Okay, so now I'm going to explain you the formula, which formula we use to count the cell viability for MTTSA. There are two formulas we can use. It's up to you which one you wanted to use. Both are fine. The cell viability, you go for the absorbance minus with the means of the negative control. Negative control means you have the media without the cells. Okay, and divided by the mean of the all absorbance of the positive control. This is, sorry, the positive control. Positive control means you have media plus cells but no treatment, no drugs. Okay, so you will take the mean and then divide the each value with mean of the negative control and mean of the positive control. Now the second formula is a cell viability in percentage. You have to take the optical density or OD of the treated samples and divided by the optical density or OD of the untreated sample, which is called the control, a mean of. Okay, so here first we have to take the mean. We have to take the mean of the control. We have a three values of means. We will plus them, sum up of these value and then divided by the 3. So first value we have 85 plus 0.74 plus 0.75. Okay, divided by 3 because we have a 3 reading. So we got the, this is a mean of control values. 0.78. Now you have the control mean. Now you start calculating your sample. You have the first reading of D1 1 micromole concentration, which has a 3 reading. You have to calculate the cell viability for each reading. Okay, so now we have the first value 0.34 365. I'm using this formula. Okay, it's easy for me, so that's why I give you the two formula. Whatever you feel comfortable and easy for you, you can use any one of them. Okay, so now I'm using this one, which is the treated sample. I have 0.365, then divided by OD of the untreated sample means, which is 0.78, and then of course I will going to, because it's a percentage value, you have to multiply with 100. So now I'm going to do this one, 0.365 divided by 0.78 multiply by 100. So now I have 46.7%. So first reading the viability is 46.7%, 46.7%. And now if I go for the other one, it has the same 0.352 divided by 0.78. And then I will do it again for the third one, 0.362 divided by 0.78 multiplied by 100. I'm just showing you how to get the mean for each value. So let's go for the second one,
0.352 divided by 0.78 multiplied by 100. So it is 45.1%. Then do for the next one, 0.362 divided by 0.78 multiplied by 100. So you will have a 46.4. So second reading viability is 45.1% and then 46.4. Now I will calculate all of them. 46.7 plus 45.1 plus 46.4 divided by 3, 46. So we have the point, sorry, not point, this is a 1 micromole. This 1 micromole cell viability, we have 46.0, means the cells alive after this concentration is 46%. 46% cells are alive after treating our cells with the drug 1 with concentration 1 micromole. So now I done this one. I will give you the activity. You have to do this one for me by using the same formula. You will get this one on your screen after we will finish this workshop. Okay. So today in the workshop, I explained you about the cell culture, what neurotoxin, neuroprotective reagents can be anything. It's up to you. You can target anything. Even if you want to see the vitamin C as a neuroprotective agent, you can also use that one as well. So neuroprotective agent is, I'm not going to explain about more what are the neuroprotective. It's up to you. You can use any herbal compound, any herbs, any plant extract, anything if you wanted to see is it good for the neuronal, is it good for the brain health or not. And neurotoxins, they are already mentioned in the Wikipedia. If you wanted to see, you can get the explanation and more detail about each and every model, whatever you wanted to, you are interested to make in vitro. Okay. And the second thing, in this I just run one MTT assay. I already explained you why we need to run this MTT assay, and I also give you the software explanation and some calculation. Okay, so this, because this 2 hours shortest time, we cannot do more than this one, but we will welcome you in our lab, or inshallah, if it's God willing, we will see you again, and hope you will learn from our workshop. And please write me any questions. If you have anything you wanted to ask me, I welcome you, and I'm ready to answer each and every questions for you. Okay, good luck, have a nice time. Yes, sir.
Thank you so much, Dr. Rukhsar, for such wonderful lab tutorials, and it is so wonderful to see you after such a long time.
Yes, I'm happy to see you, Sadaf. It's nice to meet you again. There was a long time, like 7 years, right?
Yes, and I just remember our laughters and giggling all the time, because it was like we were actually like kids at that time.
Yeah.
And now it is like, it was first IBRO in Pakistan that actually joined us together, and this is the 3rd school of neuroscience in Pakistan.
MashaAllah.
Thanks to Simon for connecting us again, and hopefully I think you have an activity here to share.
Yes, yes.
So that we can, how much time for this?
They can do at least two calculation for me, and then later you can send them this for their homework, and they can submit me later if it's possible.
Okay.
So we can give them the 10 minutes.
Yes.
I will just give them the brief explanation what actually this is. Okay, students, I just explained you about the MTT assay calculation. This is a cell viability count, but it is totally different than the one we have did with the hemocytometer. Okay, so here I did the calculation, and I give you the example for one calculation, which is the drug 1, concentration 1 micromole. I already fill all the blanks here, so you have to do this calculation for me for D1 5 micromole, D1 10 micromole, D1 15 micromole, and 20 micromole. But we don't have enough time, so I will request you at least do for me a 5 micromole and 10 micromole. You will see the formula. You can use both formula, whatever you want. Okay, that's why I shared the both formula, and see the example how I did the calculation. Just follow the same step and do it for me. Okay, and give the answer on the chat box. If you have any questions regarding this, please ask me in the chat box.
Ruxana, Dr. Ruxana, we have a question.
Yes, please.
One question is by Osama Usman on our YouTube channel, that what is the effect of serum-rich media on human memory affecting cells?
Okay. Osama, I saw your questions on the YouTube comments box. It's very interesting and very important questions you ask. Okay, when you work in the in cell culture, you have to select which cell lines you are targeting. There are many cell lines. Okay, so based on these cell lines, you choose your media, and after that you have to see this cell lines is growing. Either you need to grow them lower serum media or rich serum media or without serum media. Okay, it's this Mr. Osama, this in rich media and without media, these are the conditions. When we wanted to see our cells growth, and we want to see if our cells is growing without media, less serum media, or a rich media, how their expressions will, how their growth will affect the inside the organelles and DNA and other. We did one experiment, and this paper, inshallah, you will see. If you wanted to read my more work on regarding neuroprotective or neurodegenerative model, recently I published one paper in a Saudi pharmaceutical journal. You can see the target is barbinol anacardic acid, where we explain each and everything about that one. This is, we target a PC12 cell lines, and we did neuronal damage model. Okay, so it's available free. So you can see this one. So this rich media, less media, and without media are the conditions. If we wanted to see effects on the same cell line, so it is, if some cell lines they need a really like a neuronal cell lines, it's a different case where you need not a serum. You can use the serum concentration same as you are using for the other cell lines, like a 10%. But in other nutritions like amino acid and protein level should be high. So the neuronal cells, when we grow in the cells, we use the different media which has a high nutritions regards of amino acid and other one. But if you are using some other cell lines, they are asking the targeting mostly 10%, but some cell lines really need a high nutrition media. So especially the protein and growth factor, because they need a special growth factor. That's why you need to increase the concentration of the serum in your media. So this is actually depend on your cell lines. Not all the time you are using the serum enriched media on the cells. So it's depend which cells you are targeting and which model you are targeting. Okay, I hope my explanation will helpful for you. If not, then you can write me an email, ask me any questions in my email. I will give you the explanations and with the reference, inshallah.
Dr. Ruxana, there is one more question by Mr. Shuja Heather, that how neuroprotective interact with blood-brain barrier in vivo.
I just, before this session, I explained it. But I will explain again. Blood-brain barrier is actually a semi-permeable border. It has a channel and diffuse like a channel and ions that those who can cross it. So when you are targeting neuroprotective agent, you first have to see their solubility. Where they are soluble, they are water soluble, they are some special needs requirement like DMSO and other media. So based on this, you will target. If the solubility in some acid and other things, of course, you cannot do that one. That's why the neuroprotective agent, before targeting neuroprotecting agent, you must know about their solubility. Either they can close blood-brain barrier or not. So here we always do that one. Is there any other question?
Actually, the Josha Wilson is actually asking about that 5 micromoles means 60.5%. I think he's asking that. If you can see in the chat, if you can see in the chat.
Okay. He did the calculation for the one I did it. Okay, yes. I just 60.5%. Yes, you do. I will tell you the answer. I cannot tell you now because other are doing. Okay.
And there is one question, Roxana, is there any way to investigate potential predictive ability of DNA methylation?
I already explained.
Okay, so they are actually posting it again and again, the questions. I think they...
Okay, I will explain
no
again.
No problem. You don't have to answer again. Because
no problem. I can explain it. No issue. If the students didn't get the and didn't understand from me, I will explain again. Okay, DNA methylation is actually the epigenetic mechanism or a modification which affect the gene expression level. If you are really interested in a DNA methylation, there are many assays or protocols you can target them. But first you have to see you are targeting DNA methylation gene expression in our blood samples, in our tissue samples, in our cells, direct cell lines. Okay, based on this one, and then you can go for the microarray technology. You can go for the advanced sequencing assay. You can also target the single cells methylation assay, and there are other way you can do that one. So this is if your DNA methylations you are really interested, you can also target in a blood samples and gene. Recently, one of the master students, she published a paper on based on this epigenetic effects on gene expression in a depression. So you can also find the paper online. Okay, how they come out from the brain. This is what I think someone asked me. Let me check again. Lipophilic compounds after metabolic convert into hydrophilic form. Then okay, this is you are asking me these compounds look, we are targeting neurotoxin and protective. If you are targeting neurotoxin compounds, how they enter and then come out, then of course if neurotoxin is, that means they are killing the cells, and then of course the cells once death, then they will come out. If you are asking me on neuroprotective compounds, so this is I cannot tell you right now that how, because I didn't do that chemistry level. But first, what we are doing, we are checking their solubility and their ionic conditions. Based on this one, we are targeting. And sometime when we target these compounds, we don't know, because we are mostly in our lab we are targeting the herbal compounds and their active agents. Okay, so when we get all the detail from the direct from companies, so we know that these compounds are either hydrophilic or lipophilic or this, but some here we direct use the extract. So what happened if we don't know their things like a hydrophilic or lipophilic? So we did not get any results. You got it. Said that we should know how we can know about their chemistry, then we can treat them with the brain. But this, honest with you, I cannot give you the correct answer how they will come out. Okay, because till now we did not get some kind of experience with these compounds. Mostly we are using the hydrophilic here. And we found the effect on the human brain, and we found the very good results. Is there any other question? Some use the 1066. Yes, okay. Yes, those who did it 60 and 67, and most of them, they are doing 66.3. It's okay, because this is some, after points variation, so no problem that one. But you all are doing good. This is the actually percentage you will get it. I see who answered. Sadia, she answered, and Maha answered, and Rushda answered, Joshua answered, and who else is there? Okay. Yes, now I just want to explain you when we did the viability in percentage for the concentration 1 micromole, it was showing 46.4, and the second is showing the 60, and the third is showing the 66%. Can you see the increment in the percentage level based on the concentration? So what you understand based on this one? So your lower concentrations giving a less is killing less amount of the cells, but as you increase the concentration of that drug, and the same you will use as a neurotoxin agent. If you wanted to, you don't know that the neurotoxin agent you are targeting for the brain death, which concentration is giving actually the lethal effect. So you can also do the MTT assay to find out the lethal dose of the neurotoxin, and same you will do for the neuroprotective compound to do the MTT assay to find out the which is actually a protective dose, because some here 1 micromole drug is showing a 46. It means the 46% 7th are cells alive. Then you see the concentration is increasing, the percentage of the viability is increased. So means the higher the dose of the drug, it means higher the viability of the cells. You understand this concept? Same things you can do for the neurotoxin. You cannot do just randomly target the one dose and start running your experiment. First, you need to do the MTT assay to find the lethal dose for the neurotoxin. Then the one dose you will target. First, you will cause the damage in brain cells. Then you will do these different concentration of neuroprotective agent to see the protective effect. How many people have done? Okay. So other are doing, okay. So Dr. Sadaf, so we have enough time, or you can share my email with them so they can write me any questions they have.
Yes, yes. If everything is done, we can conclude the session as per your suggestion, because they can always write to us for the email as well, and they can also write to us directly, and we can let them connect with you.
Yes, yes, sure. I'm happy to answer all of you, and I'm happy that you are understanding the lab session and you are asking the questions, and you also giving me the answer on the worksheet. I'm really happy, and I love these students, those who are willing to learn. And of course, my lab is open for all of you. If you want to do any collaboration work, write for me. I'm happy to serve you, inshallah. And she's my master student, Miss Wala. She's also working on the neuroprotective agent. She's also doing neuroprotective disease model in vitro lab, and also doing the animal model. No, human. She's also targeting human addiction model.
Dr. Ruxana, please tell us. Okay, this is question for Dr. Ruxana, because she said her lab is always open. So give us suggestion how we send our student from Pakistan in your lab.
Look, there is no problem. You can communicate your supervisor, ask them to write us email. You are welcome, but right now don't write any email till Corona. Because UAE stopped the flight since 3 months, so no one can enter, no one can go. Okay, so you can, of course, you can come through your supervisor permission, and we will open the lab and we will serve you, inshallah. We will see how we can manage that one. Okay.
And definitely, Dr. Ruxana, because this is the new lab open to us. So there are so many collaborative programs that the student always looking for when they do their work for PhD and MPhil. And
Yes,
they
yes,
always
sure.
look for the sandwich program and the labs where they can go and learn about some techniques and do some of the work. So this is very good. And you are asking to just open up yourself to the wrong people, because we never let go people.
Yes.
No, I'm a Pakistani. Don't say this. I'm a Pakistani. That's why I said, or by the way, I just give you the little introduction about my lab. My lab is not only based on the cell culture. My lab is a big lab, and I have an immunohistochemistry section. I have a molecular biology section. I have a cell culture section. So anyone who is interested in 3 sections, you can contact me. And believe me, my university, my department love to do the collaboration with you people. And we are already doing. Ask Dr. Simon Bull, ask Dr. Iram. So we all are in a collaboration, and Faisal, Faisal who is doing, and he's also coming and doing the participating in our lab. So please don't take me like I'm telling you and asking me just because the conference. No, I'm ready to help you. Okay.
Dr. Ruxana, participants want to know, like you are doing cell culture. So they wrote in the chat box that like in vitro study or cell culture in psychology lab.
Okay, this is a good question. Actually, my expertise is neurogenetics. I have completed my PhD from College of Molecular Medicines, ICCBS, and then I joined this behavior neuroscience lab. Actually, we are connected with the College of Medicines, and our department is a clinical psychology. Clinical psychology is little bit different from the psychology.
Social science.
So that our psychology. Our psychology department is in our College of Humanities and Social Science. Our clinical psychologist is a part of College of Medicines and Health Sciences. So we are mostly doing this kind of work. My degree is not in psychology. Be aware about this one, okay? So don't think I have my master in genetics and my PhD in neurogenetics. So if you want to know more about my interest or my works, you can go and write my name in a Google. You will find all my publication, all my interests. So you will know, so on basis of these interests and what kind of work we are conducting in our lab. So you will see. We have, mashallah, completed a lot of project in the lab since 7 years. I'm working in this lab, and we have, mashallah, have a lot of grants. Now we are also applied for a big grants. I'm a part of that grant and co-investigator of that grant. If we have some funding, wallahi, we will, sorry, I used to say this word wallahi because I'm in Arabic people, so I used to use this one. We love to collaborate and help you financially as well. Okay. I cannot see students who's writing on the YouTube. I can only see the any questions on the Zoom. So if there are any questions, Sama, if you can see on the YouTube. If you have any questions, please write me email. And regarding the collaboration, just settle down these corona care things, and then you can ask your supervisor, ask them to write us what kind of work and your interest, your project. We will help you. If these things we are running already in the lab, we will let you to come and do this part of the project in our lab. Okay, Aksa got 77.5% for 5 molar. Okay, it is little bit higher than the other concentration. Okay, Aksa, I will check it. I hope that you use the same formula. There the role of CBD and the HTML. There, of course, there is. So now Dr. Sadaf will kill me before you just write everything to me email. Okay, I will explain you everything. Because I have the lab session with my students, so she's waiting for me. So I will.
Yes, sure. Thank you so much.
You're welcome.
Thank you so much,
You're welcome.
Dr. Star, for your precious time. And
yes,
as we are very much interested in the behavioral neuroscience and things, so let us wind up these sessions and then let us plan something on a specific research project.
Yeah, sure, inshallah.
Thank you so much.
Okay, everyone, thank you. Okay, see you, inshallah. Bye.
Thank you, Saima, for all the efforts and for all the assistance. Are there any other activities that you have planned, or we will close the session?
No, now you can close the session.
Okay, thank you so much, Saima, and to you and to your students. I know that the weather of Islamabad was so so serious yesterday and the day before yesterday, and yesterday when I tried to contact you, so your cell was also off and you were communicating via the landline, and I can imagine the seriousness, and we were so cruel that we actually looking forward to go smooth for this session. So we actually pushed you to just complete the session. Thank you so much. And we will, inshallah, send you about the feedback. And also if there are some certain questions or certain requests to connect with you guys.
Okay, sure. Thank you so much. Thank you so much.
Thank you so much, participants. I hope that today was a very fruitful day and it is supposed to teach you something, and the take-home messages are so many, from Dr. Jerry Devore to Dr. Taqir Ahmad and Dr. Nasir Razawan and everyone. So we have tried our best to gather people and experts from various expertise. And tomorrow we will be starting session from Professor Dr. Vaste, who will be talking about some clinical aspect of the neurodegenerative disorder. He is the professor and head of neurology at Aga Khan University Hospital. And after that, you will have to bear me for some psychopathological and impact of early life stress and daily life stresses on the aspects of neurodegeneration and how we can control them and how we can manage them, or I can say that how we can impose the simple lifestyle to improve them. After that, we will be having Dr. Nasir Razawan, who will be actually talking about his work on Parkinson's and how to treat Parkinson's, some management techniques he is trying to establish in Lahore here. So he will be talking about that, and followed by Shamu Naushad. He will be talking about the research methodologies, research designs, and some analysis that you can easily use on the population-based studies, and what are the errors people do to conduct these studies, and what are the design mistakes, what are the ethical mistakes, and what are the hitches that make them the bad researches, and with the help of the public and epidemiological research, we will explain that. So looking forward for all of you tomorrow. And please use the same link for joining the session, because people are confused that maybe we have to send the link daily. We only have to send the link of YouTube channel to all the participants who are attending via YouTube. But for the Zoom session, all of you can use the same link. Thank you so much, and don't forget to fill your feedback forms. Thank you.